cardiothoracic anesthesiologist, and I request our president, Dr. Gaurav Mitra, to give welcome speech, and then we will start our program.
Very good afternoon, everybody. I welcome you all for today's webinar on the practice of cardiothoracic anesthesia amidst this COVID pandemic. The COVID pandemic has caused a huge loss to the entire world, and we are still struggling to deal with it for over a year. So today's webinar will highlight on the insights, the challenges, and the way forward in our practice of cardiothoracic anesthesia. Today, we have nationally reputed speakers, moderators, and panelists for the sessions to follow. I thank them all for their contribution and also thank our Scientific Secretary, Dr. Shoumi Dash, and Secretary, Dr. Ashok Verma, for organizing this webinar. So without wasting much more time, I will request Dr. Shoumi Dash to start the session by moderating and introducing the faculty. Thank you. Best wishes. Over to Dr. Shoumi.
Thank you, Dr. Gaurav. The theme for today's webinar is Practice of Cardiac Anesthesia nearly a year into the pandemic, Challenges, Insights, and the Way Forward. So to begin our program, the first lecture is on the effect of SARS CoV2 virus on the human body, specifically relevant to the practice of cardiac anesthesia. For the same topic, the moderator is Dr. Shanta Dutta, who is the director of NICED here in Kolkata, and the speaker is Dr. Megha Brijwal, who is the assistant professor, Virology section, Department of Microbiology, AIIMS, New Delhi. So I would please request our moderator, Dr. Shanta Dutta, to take over from here. Thank you. Madam, if you can take over from here, Dr. Shanta Dutta, madam.
Can you hear me now?
Yes, we can hear you, ma'am.
Yeah. Very good afternoon. This is a very important webinar with respect to COVID-19, which has taken toll almost for 1 year, last 1 year. And I am also privileged to be here in this webinar. So this is actually a very good topic, which will be useful for the practitioners as well as for the anesthesiologists, as well as for the basic scientists. So I would request Dr. Megha from AIIMS, Megha Brijwal, Assistant Professor, Virology Section, Department of Microbiology, to deliver her speech and deliver her speech on the topic as mentioned by Dr. Shoumi Dash. So please, Dr. Megha.
Ma'am, please put the slides on.
Dr. Megha, you can do it from your laptop. Can you present it from your laptop?
Okay, sure, ma'am.
Yeah.
Is it visible?
Yeah, can you? Yes.
Yes, it is.
Right. Good afternoon. The practice of clinical medicine has changed drastically in the pandemic era, and I extend my gratitude and appreciation for the organizer to bring together everybody here for this webinar. I'll be talking about effects of SARS coronavirus. My subsequent speakers would be talking about its clinical effects and challenges, and but I'll be primarily focusing on the pathogenic basis for these effects. Right. So we know coronaviruses are actually ubiquitous group of viruses. There have been 4 circulating human coronaviruses already in human population, but these have been primarily associated with mild URI or laryngotracheobronchitis. LRTI was seen rarely, mainly in immunocompromised. But in 2002, SARS coronavirus emerged, where the reservoir was found to be civet cats. And in 2012, a Middle East respiratory syndrome virus appeared, where the reservoir animals was identified as dromedary camels. 2019 has seen a huge shift with emergence of this novel coronaviruses, which have been renamed as SARS coronavirus 2 due to its homology with the SARS coronavirus, which was identified earlier. Till now, there have been about 83 million cases worldwide, with India accounting for about 10 million cases. If we compare the fatality rates, SARS coronavirus 2 actually have a lower fatality rate compared to its two predecessors, which have caused outbreaks. But in sheer numbers, it actually, defeats all these previous one because of its high transmissibility. Looking at the virology, we know it's an enveloped RNA virus. The 30 kb genome codes for non-structural and structural genes. The structural genes are the one which constitute the structure of the virus. So mainly these structural genes are envelope, nucleocapsid, and matrix. One of the most important is the spike glycoprotein, which is a trimeric molecule present on the surface of the virus. This is the most crucial one because it is the one which is involved in attachment and entry into the host cell. And this is the target against which the neutralizing antibody forms. And this is what we assess as a result of exposure or vaccine response. A limited amount of genetic variation has been seen in this virus, which you must be seeing with emergence of a UK strain, a South African strain, and Nigerian strain. Most of this are occurring as a part of a natural genetic drift or spontaneous mutations which occur in virus. This is an RNA virus, and RNA-dependent RNA polymerase has an inherently error-prone replication. So this is actually a very common feature in RNA viruses. In coronaviruses, I would actually say this variation is much lesser compared to other viruses because there are certain mechanisms which sort of remove this error-prone nucleotide insertion whenever a replication is occurring. Less commonly, a genetic recombination-like event can also occur, though it is very rare, and this is the one where interspecies jump in coronaviruses are seen. Looking at the transmission, the most common mode of transmission we know is the droplet or contact precaution. Airborne has been sort of postulated, but there is not enough clinical evidence. A fomite transmission spreading through cell surface, through the various hard surfaces has also been proposed. The reservoir here, the COVID-19 spreaders, what we call, are basically the symptomatic patients who are coughing and sneezing and spreading the viruses. But patients who are asymptomatic or pre-symptomatic have also been said to be a source of transmission. Now, this virus has been seen to affect certain risk group more. Common complications are seen with old age, coronary artery disease, diabetes, hypertension, malignancy, and other immunosuppressive and chronic conditions. Primarily, looking at the scenario that a cardiac anesthetist is facing, is he encounters a COVID-19 case while managing a cardiovascular patient. This either there is a patient who already has a cardiovascular disease and now has come and is now a suspect or a confirmed case of COVID-19. This encounter may occur during surgery, during peri-operative period, or even in the post-op care. In another scenario, patients who have COVID-19, who has never been identified as somebody with cardiovascular disease, end up having a post-COVID-19 cardiac complication. So in this scenario, it becomes more tricky, and an encounter may be faced during any urgent cardiac procedures which may be needed. That is why at this time, it is necessary to actually encounter every patient as a suspect COVID-19 case. Now, looking at the basic pathogenesis, we know after an incubation period where the virus enters, it takes about 2 to 14 days. That is on an average about 5 days. And the virus starts replicating in human body. Initially, the viral load is very high. And we have seen that even in the pre-symptomatic period, we get a lot of PCR positivity as reflected by, which shows the presence of virus. As the virus increases, clinical manifestations are also formed. And as the viral load reduces, the antibody response simultaneously can be detected in patients. In the clinical presentation, there are a spectrum of infection ranges from asymptomatic, oligosymptomatic. Oligosymptomatic is the group where symptoms are mild enough to be missed and patients generally sort of remember them after they are incidentally found positive, or they are symptomatic with mild, moderate, severe disease or a critical disease. Now, characteristically in COVID-19, the patients who have severe or critical disease have a multi-system organ involvement. So why that occurs is sort of our basis for learning the pathogenic basis of the disease. Now, first is the first exposure of the virus to a host cells that occur. And this primarily occur through the target cell receptor, which is the ACE2 receptor. The spike protein, as discussed earlier, is the one which encounters this ACE2 receptors. This ACE2 is widely distributed in the body, commonly present in lungs, myocardium, kidney, intestine, and many other organs. After this, there are various proteases or cell-associated different enzymes which can cleave this protein and sort of internalize the virus. And here, the virus is being endocytosed. In this state, the viral genome is released outside, and we know it is a positive sense RNA virus. That is, it can act as an mRNA. So it will start producing some of the proteins, and the initial proteins formed will be the non-structural proteins, which are mainly the enzymes, which helps in its replication. After that, the genome itself forms its complementary copy, and virion or progeny viruses are being formed and assembled. This is then extruded through the cell. It's being pinched off as it's an enveloped virus. Right. Talking about its first exposure, we talked about that its first primary route that we know is a respiratory route. So the first cells that it's primarily encountering is the ACE2 receptors, which are present in the pulmonary epithelial cells. In the respiratory system, it is present in the pneumocytes, as well in the alveolar and also in the capillary endothelial cells. In this encounter, we know that there is an inflammatory response which is being generated. In most of the scenario, that is up to 80%. We know asymptomatic or a mild infection is seen and most of the patient recovers. But in certain group, a severe or a critical illness may be seen where there is a significant hypoxia and ARDS might be manifest. Characteristically, this progression is very rapid in COVID-19 cases. There are not just the pulmonary, but extrapulmonary effects which are seen. And this occurs because the target receptors, the ACE2, as we earlier discussed, are widely distributed. So the severity and organ damage is actually reflected clearly with the ACE2 distribution in the body. So while it encounters this receptor and able to replicate in almost all the different organ system, today we are focusing on its cardiac damage that it occurs. So as the receptors are present in vascular endothelials and myocardium, the complication would be similar in both of these systems, which we are going to elaborate a little further. So conditions which are actually relevant to the practice of cardiac anesthesia, especially the cardiovascular consideration, would be a patient with an acute coronary ischemia. Most often, a patient is presenting who has a cardiovascular disease, or whether it is already identified, or sometimes in cases it was actually identified on that presentation only, is acute coronary syndrome, where the patient have a plaque rupture or a stent thrombosis, or there is a stress due to a supply-demand mismatch which is occurring. The pathogenic basis for this ischemia is generally a systemic inflammation, because COVID-19 is sort of creating a pro-inflammatory state in the body with a huge cytokine storm. And also there is a thromboembolic phenomena which is happening, because it's actually leading to a prothrombotic state. So there are various vascular microthrombi which is being formed, and which is leading to this complication. Other than that, patient can actually present with myocarditis, and there have been case reports where patients have presented with myocarditis without any respiratory symptoms, without fever or cough. The pathogenic basis here has been attributed to either a direct viral injury, because as we said, viruses are able to replicate and there is a cytotoxic cell damage in the myocardium tissue, or it is due to a cytokine storm which is occurring with systemic inflammation. The myocarditis may be either alone, it may be with or without pericarditis, or patient can have cardiogenic shock as well. Other than this, patient can also have a shock which is vasoplegic in nature, or it's more of a septic shock. And this is primarily due to an imbalance in the renin-angiotensin system, which is a hallmark of this disease. And there might be associated endothelial dysfunction, which is happening here. A patient can also present with a heart failure, primarily a right ventricular failure, which is often seen in patients with ARDS, where there is a right ventricular dysfunction, there is hypoxia, or it could be also be due to patients with deep venous thrombosis who are actually now presenting with a pulmonary embolism. So now we'll be talking about these pathogenic mechanisms in brief. So first, talking about the cytokine storm. We know that SARS coronavirus stimulate a hyperinflammatory response. How that occurs is after a cell is infected, there is formation of reactive oxygen species, which is the normal response to an infection. Most of the time it is balanced, but in some cases it actually leads to activation of certain other factors. So
Dr. Megha, I'm Dr. Rahul. You
Dr.
only have 1 more minute to finish your presentation.
Right, so I'll sort of go faster, right? So
Okay,
we're talking about cytokine storm, which is a major factor. And we have dysregulation of ACE system, where we know that renin-angiotensin system, ACE2 is actually a regulatory mechanism on the RAS system. And in COVID-infected cells, the ACE2 expression is down-regulated after the cell is infected. And this dysfunction actually sort of put this cycle more towards angiotensin 2 related function, which is the one which is leading to its complication. Now, there is an endothelial dysfunction with the cell damage, which is occurring in this group. There is a coagulopathy or thrombosis, which is forming due to inflammatory valvular injury and this downregulation of fibrinolytic and anticoagulant pathway. A host immune response to SARS CoV2 is also reflected in most of the cases, which is able to counter the infection. But in most of the cases, especially in the critically ill, the viruses sort of create mechanisms to evade this immune response. So whether it is lowering of the interferon pathway or it is actually dysregulated immune response. So also there have been seen that an immune dysfunction can also occur where modified macrophages are being formed, which actually have no role in anti-inflammatory response, but it actually aids towards the pro-inflammatory cycle. So a SARS-CoV-2 basic chronology, while it is counteracted in healthy immune individuals, in dysfunctional cases, you can have a dysregulated immune response. There is excessive infiltration of monocytes and macrophages, a cytokine storm, a pulmonary edema, a widespread pro-inflammatory state leading to organ dysfunction. Right. Thank you so much and Happy New Year.
Thank you, Dr. Megha, for your very informative and lucid presentation. So I think she has very clearly, she has described the pathogenesis, although it is within 15 minutes, it is very difficult. It's a very complex process. And as we can understand that SARS-CoV-2 is not only a respiratory disease, it is actually an immune complex disease where immune status of the subject who already has the infection, if it takes over, then the patient suffers from the severity becomes more in the patient. And but in most of the cases, 80% of the cases, the patient recovers without any complication. And I don't know whether now some of the participants can be allowed to ask 1 or 2 questions if they want to, or else it can be asked together at the end of the. I don't know what you have decided, the organizers, what you have decided, whether the questions will be asked now, 1 or 2 very important or very intriguing questions, then Dr. Megha will be able to respond.
Ma'am, I'm Dr. Rahul here. I'm coordinating the entire program today. First of all, I want to express my deepest gratitude that you could come in spite of your busy schedule to join our program. And also to Dr. Megha for taking time out of her busy schedule to present this. The way we are going to do this is we are going to invite questions in the chat box. And once a certain number of questions on a particular topic has come, right at the end of the program, so that the program runs on a continuous flow, we will ask the panelists to come back and the speakers to come back and might be taking 1 or 2 questions. That is the way we want to take this forward.
Okay, so then I think I cannot be present that time because I have one meeting right now. I have to rush for Shastha Bhavan, and because I have already I committed to attend this meeting, so I am here now. So, but what I can say that this is, we know all of us, actually now a new strain has come, and now everyone is has some question about the new strain, some new mutations which makes the virus more transmissible. But the major mechanism for against the virus, it depends on the host to a great extent, because it may be seen that in some hosts the virus cannot spread or cannot make that much of damage, whereas in some other host, usually with comorbidities and with a higher age group, they become. But I have seen some cases, even patients with 90 years of age also recovered without any complications. So it is we are now still in a very nascent stage of understanding the mechanism of the virus. But whatever is understood now, that this is a virus which can cause damage to many organs, not only the respiratory tract, many other organs, because of the presence of the receptors in other organs also. And this is there is some treatment modalities also. So if the treatment has the treatment guideline and the treatment algorithms have been followed, now the recovery rate is also quite high. So we can say that maintaining all the social distancing and the wearing mask and frequent hand washing with soap and water, we will certainly get over the disease, and in future we may have some new vaccines by which we can prevent the disease. Like this is very much important for us, because the 2020, the entire year, it has gone without, like I can say, it is waste of 1 year, very important for us researchers as well as local people. There is economic loss also, there is wage loss. So if we can have some vaccines and the specific treatments, then certainly we will win coronavirus together. So thank you very much, Dr. Megha, for your very nice presentation. I must say, you have tried to this very complicated topic to present, to describe it in a very lucid way. So thank you very much.
Thank you, ma'am.
Thank you, ma'am. And thank you again, Dr. Megha. We will proceed to the next part of our program today. And this time we have our next topic is intensive care of COVID patients, therapeutics and ventilatory strategies. I can see Dr. Saswati Sinha is already here. Hi, Saswati. A very good afternoon to you. I'm seeing you after a long time.
Good.
And is Dr. Suresh with us, Dr. Shobi or Dr. Ashok?
No, he is not there, probably.
Okay. So it will be my pleasure and delight to introduce Dr. Saswati Sinha to our audience here. Dr. Saswati Sinha is a senior consultant in hospitals Dhakuria, and she is a very senior person in the field of critical care medicine and has acquired quite a bit of experience and learning in managing COVID entire pandemic. Without wasting any further time, Dr. Saswati, please proceed with your presentation.
Thank you, Dr. Rahul, for your kind introduction, and thank you, organizers, for having me to be a part of this interesting webinar. Just sharing my screen. Are my slides visible?
Yes.
They are? Okay. So good afternoon, everybody. And in the next 15 minutes or so, I'll just be going through the intensive care of COVID-19 patients, just touching upon therapeutics and a little bit about the ventilatory strategies. So to summarize the SARS CoV2 problem in the intensive care, we know that out of all the patients, about 20% might require hospitalization. and 1/4 of the hospitalized patients might require intensive care. Again, the proportion of patients which require intensive care will be determined by the ICU admission policies, the caseload. So every hospital will have their own policies. The onset of dyspnea is usually late, but the progression to ARDS may be very swift. What we need to understand that profound hypoxemia is usually the norm, and of all the hypoxic patients, about a third to sometimes if in very sick ICUs, most of them might require invasive ventilation. The length of stay is usually longer in COVID-19 patients who land up in intensive care as compared to ARDS due to other non-COVID related problems. And although the lungs are predominantly involved, we all know that the SARS CoV-2 can involve many other organ systems. So the crux of the management again lies in categorizing and identifying the group of patients which are high risk. So normally the patients whom we will deal with in the intensive care unit is anybody in group B or group C. So somebody with a moderate pneumonia who's becoming tachypnic, and now the oxygen saturation is going down beyond 94. And what we need to understand is once the saturation starts dropping in the COVID-19 patients, sometimes we can see a downward spiral going very rapidly. So we are normally going to deal with patients who are hypoxic in the intensive care unit. So apart from the hypoxemia, there are certain high-risk features which we need to keep in mind, and which include, again, patients with comorbidities, like Dr. Megha has already touched upon, somebody with an underlying ischemic heart disease. Obese patients usually do not fare very well. And clinically, again, significant hypoxemia, saturation going down to below 94 on room air should really raise the alarm signals. And anybody who is overtly tachycardic, having respiratory distress, and if the sensorium is altered, these are the patients which require a close management. And if we look at the lab values, lymphopenia is a bad prognostic indicators apart from the elevated inflammatory markers. So while we go through the therapeutics, what we need to know intuitively that once the patient comes to the HDU or the ICU, we need to have these patients hooked up onto the monitors. And like we said, that because the oxygen saturation is the prime determinant which helps us choose the therapeutic options, it's very important to have the pulse oximeter connected at all points in time. The patient needs to be administered oxygen if the saturation is less than 94% on room air. Ensure adequate hydration. Avoid NSAIDs other than paracetamol. Avoid nebulizers unless mandatory, because they are aerosol generating, and it poses as a hazard to the healthcare workers who are going to treat the patients. There was an initial notion that, because SARS-CoV-2 binds through the ACE2 receptors, and so patients, whether on ACE inhibitors or ARVs, whether they need to be continued or whether they need to be stopped. But now it's proven beyond doubt that somebody who's been on ACE inhibitors or ARVs should be continued on their usual therapy, and we should not try to change things at this point in time. Again, since SARS-CoV-2 produces a prothrombotic state, if you're talking about the therapeutics, we need to understand that anticoagulation also forms an important part of the therapeutics. Every hospitalized patient, especially the high-risk patients, should be at least on a prophylaxis dose of heparin or low molecular weight heparin. Whether the anticoagulation needs to be intensified, there is a lot of controversy that because we see grossly elevated D-dimers, and there have been several groups which have proposed that therapeutic anticoagulation should be decided based on the D-dimer values. But usually there should be an attempt made to demonstrate a thrombus, because as we know, a lot of patients might be elderly, may have other comorbidities which can increase their propensity to bleed. So just basing anticoagulation on the basis of just D-dimers may not be a very prudent thing to do, but sometimes we are forced to do it if the patient is too sick or the patient has a renal impairment and cannot be subjected to a pulmonary angiography in order to demonstrate a thrombus and is getting more hypoxic. So talking about therapeutics, we really have very few options in our armamentarium. And when we talk about effective therapeutics, I think steroids go beyond doubt, and dexamethasone, especially after the landmark recovery trial, it has shown that a low dose of dexamethasone of 6 milligrams per day, up to 10 days or until discharge, whichever is shorter, this is very effective and should be given to all patients who require oxygen, whether it is low flow oxygen, including ventilated, as well as patients on ECMO. And these are the only group of drugs which have been undisputably shown to reduce the mortality. However, it's very important to understand, because we find a lot of patients who are coming in from home and they've already been started on some kind of a dexamethasone or some kind of an oral steroids when they were not hypoxemic at home. And it's very clearly shown in all the studies and the meta-analysis that if the patient is not hypoxemic, steroids can be harmful. There are certain studies which have also studied hydrocortisone, methylprednisolone, or prednisone. However, the data is limited on that. The advantages of steroids are they're easily available. They do not cost much. However, we need to keep in mind that patients on dexamethasone are severely dysglycemic. And as we know that altered blood sugar levels can predispose the patients to secondary infections. So next is remdesivir, and remdesivir is indicated for hospitalized patients from moderate to severe COVID-19, definitely on those who are requiring supplemental oxygen, especially the ones who are on low flow oxygen. It's not very beneficial if the patient is very sick and is already on mechanical ventilation or ECMO, but we can still continue to give that. The dose is 200 milligrams per day on the day one, followed by 100 milligrams per day for the next 4 days, and it can be continued up to 10 days in patients with severe disease. It has been shown to have a faster time to clinical recovery, and there are certain studies which have shown that in patients who have a reasonably lower oxygen requirement, there is a trend towards a mortality benefit in these kind of patients. We need to understand that these have some GI side effects. We cannot use this if there is a grossly elevated liver transaminases, and it's usually not recommended in a patient with a creatinine clearance of less than 30. However, now it's gone to show that if the benefits outweigh the risk, then it's probably worthwhile going ahead and giving it to the patient, especially with borderline creatinine clearance. However, we need to understand that we should not club it with HCQS or chloroquine, because it can cause serious cardiac side effects. Is the Janus kinase inhibitor, which is normally used for the treatment of rheumatoid arthritis, that is baricitinib, and the FDA has issued an emergency use authorization only in combination with remdesivir, 4 milligrams per day up to 14 days, and it has been shown to reduce time to recovery more, and found to be more beneficial in patients who are already on high flow nasal oxygen or NIV. And it's also shown a trend towards a lower 29-day mortality. However, it's not statistically significant. It should not be used alone without remdesivir. However, if the patient has no contraindication to glucocorticoids, it's prudent to use glucocorticoids rather than go ahead directly to baricitinib, because we still do not have enough data yet. There was a huge use of tocilizumab, that is the IL-6 pathway inhibitors. However, now we already know that there is a huge cost. It causes associated immunosuppression. And the randomized control, although the observational studies showed some fascinating results, the randomized control trials have shown that it really does not benefit. It does not reduce the need for intubation, neither does it have any outcome benefit. Convalescent plasma is basically the idea with which convalescent plasma was started. It's to provide a passive antibody-based immunity, and it was postulated to reduce duration. What it was, although again, there was certain observational studies or certain studies which came from Argentina, which showed that it can really cause a benefit. However, there is an Indian study, the PLACID trial in India. It has shown no reduction in mortality or disease progression. However, what is very important we need to understand is the optimal timing. The best timing is within 3 to 4 days of symptom onset. And also the antibody titers in the donor plasma is very important. So if the antibody titers are suboptimal, it's obviously not going to make a difference. So we go on to oxygenation targets. The recommendation is we need to maintain more than 94% during the initial resuscitation, and those in severely hypoxic patients are requiring huge amounts of oxygen. More than 90 is usually reasonable. We should try to use the lowest possible FiO2 to maintain the target oxygenation, and at all costs avoid hyperoxia. When we progress to when the oxygen requirement increases, we might sometimes be forced to use high flow nasal oxygen. There was a huge resistance towards using high flow nasal oxygen in the initial parts of the pandemic because of the risk to the healthcare workers because of aerosol generation. However, it's now been seen that you can, if you're taking all the precautions, and high flow nasal oxygen as well as NIV can be used. However, we need to keep in mind that we should not become complacent once we put these patients on HFNC or NIV. We should set a timeline, and basically we need to understand the point in time when we know that this is failing and the patient needs to go on to invasive ventilation. There are certain precautions when these patients are on HFNC or NIV. Basically, it's to protect the healthcare workers from aerosols. Again, use the lowest effective flow and FiO2, avoid nebulized medications. For NIV, try to use a full face mask rather than a nasal mask. Try to use a dual limb circuit with an invasive critical care ventilator, so that the exhaled air does not come out into the environment. Avoid nebulized medications, avoid chest physiotherapy, avoid bronchoscopy in non-intubated patients unless it's a life-threatening indication. Awake proning was started when there was a huge surge in cases in the New York hospitals, and it was shown that awake proning can help in improving the oxygenation. And however, we also need to keep in mind that the patient should have a normal mental status. The oxygen requirement should not be extremely high, and the patient should be able to prone with minimal assistance. We should try and avoid awake proning in hemodynamically unstable patients or patients who are obtunded, and in situations where we will not be able to monitor these patients. So basically it's 30 to 120 minutes in the prone position, and then the right lateral, then make the patient sit up for 60 to 90 degrees, and then left lateral recumbent. And it's really shown that with a little bit of assistance, sometimes these patients might be able to tide over the crisis. So this is a patient on high flow nasal oxygen in our ICU who's effectively proning, and we see a significant improvement in the oxygen saturation. Now,
Saswati, only one more minute you have.
Okay, I'll just try to speed it up. So optimizing the timing to intubate is the most challenging. Always have a low threshold if you see a rapidly progressing respiratory failure, high oxygen requirements, alter mental status, or hemodynamic instability. All the aerosol generating procedures we should be performed. Most experienced person intubate. Try to use rapid sequence induction always. Prevent bagging. Whenever you want to disconnect the ET tube, always make sure that it is clamped, and once the ventilator is connected, only then unclamp. There were these boxes which were started, in order to help intubation or to reduce aerosols. However, if the skills are not good enough, it can produce significant delays in intubation, which can be fatal for the patient. Again, all COVID pneumonia are not ARDS. Some of them have a high lung compliance and some of them have a low lung compliance. Ventilation usually follows the standard ARDS net protocol. Those who fail low tidal volume ventilation, prone position must be tried, and it's been shown that prone position does help in improving oxygenation. If prone fails, we need to know which are the patients who will benefit from ECMO. Of course, Arpan is going to talk about ECMO, so I do not need to touch upon that. What we need to understand is in a pandemic situation, our priority is to ensure that everybody gets monitored beds, adequate oxygen and pulse oximetry. And while ECMO is a life-saving modality in refractory hypoxemia, it should not be rushed to the front lines in a pandemic situation. So identify high-risk patients, use steroids, especially in hypoxia, give HFNC and NIV a fair trial before intubating the patient, optimize the time of intubation, prone early, and select the patients carefully, those who will benefit from ECMO. Again, sharing a few of our COVID stories, it's not that grim. It's very heartening to be able to send home very sick patients. Thank you, stay safe, and a very happy new year. Thank you again, the organizers, for giving me the opportunity.
Thank you, Dr. Saswati, for a very comprehensive presentation of the intensive care management of COVID patients. Unfortunately, we have taken up our time, so we will invite all the audience members to put up their questions in the chat box. And at the end of the program, we'll take some of these questions and have a discussion on them. So we will proceed to the next part of our program, which is a review of peri-operative testing guidelines for COVID. It's such an important issue. And do we have Dr. Ansuman Mukhopadhyay with us?
Yes, he has joined.
Dr. Ansuman Mukhopadhyay is a senior consultant pulmonologist in AMRI Hospital, Saltlake, and he will be moderating the session. And the session will be taken by Dr. Shoykot Sengupta, who will be speaking on the topic. Dr. Shoykot Sengupta needs no introduction in our forum. He is a senior consultant in anesthesiology in Apollo Gleneagles, Kolkata. I will request Dr. Ansuman to start the session. Thank you.
Good afternoon, everybody. Am I audible?
Yes,
yes,
you are.
Perfect.
Yes. So I'll just have a liberty I will take from the organizers because I'm traveling on the highway, so you might not be able to see me on screen. So the internet connectivity is a little low, so I'll keep myself restricted to the audio connection only. Hello.
Yes, you are audible. We can hear you.
Fine. So Dr. Shoykot Sengupta knows the introduction, and he is one of the most well-known faces in cardiac anesthesia and anesthesiology circuits in this city and also the country. We have been brother in arms in many of our travels before. So without further ado, I would request Shoykot to please start off his speech.
Thanks, Ansuman,
Shoykot,
and
please start.
Happy New Year to everybody. And I knew this was going to happen. I was going to be in the OR, and I've sent a recorded thing to Ashok. So Dr. Ashok Verma will just run that recorded session, and I'll be around live. Thank you. And Rahul, don't worry, I'm within time with the recording.
Thank you,
On
Shoykot.
pre-operative
Okay, let's start
tests for COVID-19. What I'm going to try and take you through for the next dozen minutes would be for a patient posted for an elective surgery, why do this testing for pre-operative screening for COVID-19, which test to do, when to test, and what to do based upon the result of that tests. It is mandatory in the current pandemic scenario to include a COVID-19 screening or testing for all patients who are going to undergo an elective procedure. And you have to take a risk assessment related to COVID. It is because there is a definite evidence suggesting increased perioperative morbidity and mortality in patients with COVID-19, and also because of the risk of the spread of the virus to the healthcare providers and to other patients in those healthcare institutions. Beginning from the data that came out from China, then from Italy and from the United States, coming to this more definitive publications of the COVID Surgical Collaborative in the Lancet a few months back, there is a definite increase in morbidity and mortality in patients with COVID-19. And this includes asymptomatic persons undergoing elective procedures, which is why, based for the patient, you need to test and detect and not do surgeries in symptomatics as well as in suspected and those who are still infectious after having COVID-19. We kind of have an idea today about the signs and symptoms, but COVID-19 is not a clinically based diagnosis, and you have to have a microbiological proven SARS CoV2 RNA detected to label that person as COVID-19. Whom to test? The answer is simple. It is for all patients undergoing elective procedures. Now, this is based upon the recommendations of the American College of Surgeons or the joint statements of the American Society of Anesthesiologists and the Patient Safety Foundations, so the European guidelines, and also from the infectious disease societies. Closer home, even the ICMR task force on COVID-19 says that you have to do a test, for priority being the RT-PCR, for anybody undergoing a surgical or non-surgical invasive procedures, even asymptomatic. When do you test? There is no given time, but most would say that it is best to do within 1 to 2 days prior to surgery. But this is also based upon the availability of the test, the turnaround time of the test in those particular areas. After the test, the person should be self-quarantining till that surgery happens. Which test to do? Now, the test categories are essentially of 3 types. The nucleic acid amplification tests, the commonest being the RT-PCR, and the antigen tests, which diagnoses current infections, specimens being taken from the respiratory tract, and the serology tests, antibody detection, to diagnose a prior infection from the blood. The NATs are extremely specific, so are the antigen tests, but there is a problem with sensitivity. Reported false negatives for NATs can vary from 5 to 40%, and they usually take between 15 minutes, some tests, and usually 8 to 12 hours. Unfortunately, the antigen tests are even less sensitive than the NATs, but the results can be available within an hour, which is why they are called also the rapid antigen tests. The antibody detection tests, their sensitivity and specificity are very, very variable. And there is also this chance of cross-reactivity with other coronavirus. Their results are also available within a couple of hours. But it is still today uncertain whether a positive antibody test indicates immunity against future infection. This diagram kind of would be very good in solving the conundrum as to which test to do. If you look at it from the exposure to the onset of symptoms, it varies between 5 to 8 days. And from the onset of symptoms, you'll find that the RT-PCR becomes, the nasopharyngeal RT-PCR swab becomes positive around this time, which is at the onset of 1 week. And it stays positive for at least a couple of weeks, and then maybe in some cases for 3 to 4 weeks. The virus stays positive, can be detected from the respiratory tract for a week from the onset of symptoms. And after that, you have the IgM, which starts rising around 7 to 10 at the end of 7 to 10 days. The IgG peaks around 3 weeks and stays positive for a longer period of time. So this diagram kinds of helps you to detect which one to take. The nucleic acid amplification test, the most common one being the RT-PCR, which essentially amplifies and detects different regions of the SARS-CoV-2 genome. It could be from 2 or more genomes, could be nucleocapsid, the envelope, the spike, etc., etc. Less common ones being the isothermal amplification, the CRISPR-based assays, or the next generation sequencing. The problem is not with specificity and the positive predictive value. The problem is with the sensitivity, and therefore, when the prevalence in the community becomes higher, the negative predictive value of these tests also starts going down. We'll not delve into that for today. What determines the sensitivity of the gnats are the specimen types. The lower ones, the bronchoalveolar lavages, are more sensitive. The time during the illness where you take it, between 5 to 8 days of exposure, possibly the best, and the assay type, the lab ones being the better ones sensitivity wise. Coming to the point of care test, it could be the NATs, it could be the rapid antigen tests. You could have the LAMPS and also the CRISPR-based diagnostic tests which detect the viral genetic material. But are these very accurate? Unfortunately, whether it is like things like the Sherlock one-pot testing or the COVID nuts, and also the entire types of POCs based upon this Cochrane COVID-19 diagnostic test accuracy groups, you will say that these are less sensitive than the lab test, and therefore for pre-operative screening, possibly not recommended. So which is the test that you are likely to choose? It is going to be the NAT, RT-PCR to detect the SARS-CoV-2 RNA from the upper respiratory tract. You have things like the cycle threshold, which is nothing but the number of cycles that they need to amplify the viral RNA to reach a detectable level. The lower CT values reflects higher viral levels, but unfortunately, their clinical implications are still very uncertain. So what happens if somebody tests positive? Definitely intermediate surgery, low acuity surgery, you delay the procedure. Even for high acuity surgery, you might have to consider an alternative plan and consider surgery when the patient is not infectious and has demonstrated recovery from COVID-19. So when do you say that the person is non-infectious? The CDC has two strategies. The test-based strategy is that there is no symptoms plus 2 tests of SARS-CoV-2 24 hours apart are negative. The non-test strategy says no symptoms for at least 72 hours and at least 10 days since the symptoms first appeared. The Ministry of Health and Family Welfare of India and ICMR initially would say 10 days plus 7 days preferable. I think currently the consensus arriving is 14 days since the first symptom. When do you say there is demonstrated recovery from illness? It is definitely absence of signs and symptoms, but there is no definitive demonstrable test like a pulmonary function test or a 6-minute walk test or a left ventricular ejection fraction or whatever. You have to base it upon the functional status or the MET scores or the Duke activity status index. Now let us think about certain problematic areas. You would think there is this thing called persistent or recurrent positive NATs, where there is a detectable SARS-CoV-2 RNA in the upper respiratory tract specimens for weeks after the onset of symptoms, and positive tests even after certain negative tests that are also well documented. But prolonged or recurrent viral RNA detection does not necessarily indicate prolonged infectiousness. And isolation of infectious virus from the upper respiratory tract specimens more than 10 days after onset of illness have been rarely documented. So, if you are faced with a scenario where you have had a person who was RT-PCR positive within the last 3 months, currently asymptomatic, should we test again prior to a procedure? The CDC would suggest against retesting asymptomatic individuals for the low likelihood that even a repeat positive test during this interval would hardly represent an active infection. But suppose there is a repeat PCR which is done and it is positive. Do you consider it as a reinfection? Again, the CDC would say that you would only say that this is reinfection if the time interval from the first infection is more than 90 days. There is a high viral RNA in the repeat testing with a cyclic time of less than 33. And at this point of time, there is an undetectable IgG antibody, which is not there. But reinfection can be only confirmed using genomic sequencing to establish that the infections were caused by two different viruses. That was about positive tests. Let's talk about negative tests. You have got a negative RT-PCR. Should you repeat it prior to a procedure? You do it only if there is a suspicion for COVID-19 based upon signs and symptoms. You do a repeat test. When do you do a repeat test? The optimal timing is not known, but repeat testing should not be done within 24 hours, ideally after 24 or 48 hours. There is something called the inconclusive or indeterminate test, where one of the two or more genomes that the NAT test was targeting has been identified. And in this scenario, it is better to assume that they are presumptive to be positive, and it is worthwhile to do a repeat test in this group of individuals for sure. Coming from microbiology to radiology, should we do CT chest screening pre-op for COVID-19? Based upon the Royal College of Radiologists based on the national UK audit, it is not indicated, not recommended prior to an elective procedure, because there is also always a 20% false negative, even in symptomatic individuals, forget about asymptomatic. But the Royal College of Surgeons of Edinburgh would tell you that persons going in for thoracic and upper GI surgeries, and I think this is quite rational, and you think that they would need level 2, level 3 critical care support after surgery, for risk prognostication and assessment, a CT chest screening might be useful. CT chest screening pre-op can be done where a facility for RT-PCR, very unlikely, is not available. So to conclude, I would say that persons undergoing elective surgery, yes, you have to do a COVID-19 screening because it influences outcome and also for infection control policies. The test to go to is a nucleic acid amplification test, the commonest RT-PCR. You do it 1 to 2 days prior to procedure, and if it comes out to be positive, delay the elective surgical procedure. Thank you very much for a very patient hearing.
Thank you, Shoykota. I will request Dr. Ansuman to give a very short sum up of this session.
Yes, Shoykot, you have been very clear about the type of tests that are usually done in these situations and the need for tests and when to do the tests. The only thing that I would like to ask you on behalf of the audience is, how long would you hold a test valid? Supposing there's a test which a patient has done a test prior to an elective surgery and the test is negative. He walks in for the surgery 10 days after the first test. Would you hold it valid for OT?
Yeah, I think this is a very important point, and it's a conundrum. It's a vexing issue, and which kind of bothers not only us, but I think which is bothering the whole world. I think the way that I look at it is, if the person has tested and you are absolutely certain that this person has then self-quarantined and there is absolutely no chance that this person has had a contact with an infection at any point of time, I would say it is okay. Otherwise, I think all over the world, people are sticking to this, and we also stick to this. It's around 72 hours. So if it is beyond 72 hours that the test was done prior to the admission that the person is getting to, I would be I would be requesting for a further test. So 72, sometimes we have stretched it to 96 hours, but beyond that, no. That is how we kind of would look at it.
Right. I think that's one thing. The other thing is about the sensitivity of the tests that you were speaking about. Regarding the NATs and the point of care NAT, I think the expert COVID test is probably the one with the highest sensitivity. So, according to the product information that is available, it is about 92%. So, whatever that means. So that is one test which can be done with reasonable certainty when you want to exclude a positive negative situation in a limb analysis or a blood analysis.
Yeah, thank you. Yes, Ansuman, I would agree with you. I think since we have the ability to do both the conventional lab-based RT-PCR and the GeneXpert, we have the GeneXpert platform as well. So I think what the policy we follow is it's elective, and they would come in after 48. Do the RT-PCR, go back. But if it is like an emergency, like a craniotomy kind to get in, or something that needs to get into the theater within 6 hours or within 10 hours, then possibly the GeneXpert. And we I've been quite happy with the GeneXperts.
Great. Thank you, Dr. Ansuman. Thank you, Dr. Shoykot, for a fantastic session on pre-operative testing for COVID. We will go to the next session, going with the flow of the program. And the next session is practice of cardiac anesthesia amidst the pandemic. And I would like to invite on our virtual platform, Dr. Shoibal Rai Chaudhuri, who's a senior consultant cardiac anesthesiologist and the coordinator of anesthesia services at NHRTICS, Kolkata. Dr. Shoibal, if you could kindly introduce the speakers, and we have a total time of 20 minutes for this entire session. Dr. Shoibal, please.
Thank you, Dr. Rahul. Today's session is the practice of cardiac anesthesia amidst COVID crisis. It's a very important session. Now, there are 3 lectures. First, the practice of cardiac anesthesia in adults, which will be done by Dr. Ashish Bangobash. He's a senior consultant cardiac anesthesiologist in Mission Hospital, Durgapur, and very active member of National ACTA as well as West Bengal ACTA, followed by the practice of cardiac anesthesia in pediatrics, Dr. Chandan Mondal, who is a consultant cardiac anesthesiologist in our hospital, NHRTICS, Kolkata, and he's also a very active participant of both West Bengal and National ACTA. And last but not the least, the cardiopulmonary resuscitation, Dr. Devashish Panigrai, who is a consultant cardiac anesthesiologist in Apollo Hospital, Kolkata, who is also a very active participant in IACTA as well as in West Bengal IACTA. So first and foremost, I request Dr. Ashish Bangobash to deliver the 10 minutes lecture precisely on practice of cardiac anesthesia in adults.
Thank you, Sobalda, and a very happy new year to everybody. I think I am audible.
Yes.
Hello. Yeah, thank you. So we are into the 1 year of, can you see my screen?
No, Ashish.
No, we can't.
We can see you, but not your screen sharing.
Now, no.
No.
Okay. Now, is it there?
Yes, thank you.
Yeah.
Oh, thank you. So, we are into the COVID-19 pandemic for more than 1 year, but still we do not know much about the disease except its myriad presentations and its mode of transmission. So in this scenario, infection seems to be the most reasonable practice. Unpredictability, multi-organ involvement, ineffective medications makes this a dreaded disease for the patients, but more so for a surgical patient. Human to human transmission through aerosol during expiration makes this disease highly contagious to the healthcare providers. So any surgical procedure on these patients involve high risk from the patient as well as healthcare workers' point of view. So this risk increases manifold in cardiac surgical patients because of their already present cardiovascular complications because of COVID-19. The surgical patients are more vulnerable to peri-operative morbidity and mortality, and a large number of healthcare workers involved in care of these patients makes the whole healthcare system of a hospital vulnerable to the infection. So what should be our strategy? The strategy of management should be restrict the cardiac surgical procedures to the urgent or emergent procedures, recognition of COVID-19 patients who really need surgery, and decrease the risk of peri-operative viral transmission to the co-workers. So for patient safety, these patients are really sick patients. We need to be very careful while dealing with them. These patients already have myocardial injury, lung injury, multi-organ failure, and they need extensive invasive and non-invasive monitoring and pose a huge challenge to the anesthesia team. Cardiac support and assist devices like IABP and ECMO should be available inside the OT and involve experienced members of the team so that peri-operative and intraoperative maneuver go smoothly without with involvement of minimal number of team members. These patients have higher incidences of pneumothorax, which can be detected pre-operatively by doing a CT scan, and they already have lung injury due to the COVID-19. So the ventilation strategy should be lung protective. Before closure of the chest, the lung expansion should be confirmed to ensure the proper gas exchange, and cardiac surgery procedures more often need blood transfusion, but transfusion can lead to transfusion related lung injury, reduced by antifibrinolytics, normothermia, or mild hypothermia during CPD. Coagulation factors instead of blood products when required can prevent this kind of lung injury. Inflammation due to CPD can be minimized by temperature maintenance during CPD, it can be kept between 32 to 34 degrees centigrade, heparin coated perfusion circuit, complement inhibitors, and use of glucocorticoids. During ICU stay, these patients should be monitored closely for development of ARDS, SIRS, and cytokine storm. Preventive measures like antiviral treatment should be started beforehand. So looking at the safety of healthcare team, the requirements for COVID OT is that the negative pressure and a dedicated OT with separate access from OT to ICU, isolated corridor for shifting the patient to ICU, minimum number of people should be inside the OT, minimize the movement in and outside the out of the OT during the procedure, Personal protective equipment is a must for everybody, and special protection for the team involved in ARA management should be taken. The other measures which you can take is patients should always be wearing a mask while being wheeled to the OT. Oxygen supplementation can be given through a nasal cannula, as the venturi mask can cause aerosol generation. Induction of anesthesia cannot be hurried in this kind of patient, but what we can do is we can use a faster acting muscle relaxant, so that we can intubate the patient within 1 minute, and thus we can avoid the bag mask ventilation, which is the main aerosol generating procedure inside the OT. High efficiency air filters and at the patient and anesthesia machine end should be used, and close airway suction is a must, as it generates a lot of aerosol. Dedicated surgical devices and anesthetic equipment should be there. OT doors should remain shut all the time during the procedure to maintain a negative pressure. High touch devices like anesthesia, workstation, infusion pumps, etc. Should be wrapped in a plastic to facilitate cleaning and decontamination after the procedure. During transport to ICU, a portable ventilator with HMEF filter should be used. Inner circuit of the anesthesia machine should be disinfected with alcohol, 75% alcohol. OT negative pressure must be maintained for at least 30 minutes after the patient's departure. Utmost care should be taken for medical waste disposal, and continuous assurance and support to the health.
Ashish,
yeah,
10 minutes are over. I think they will give you another grace 1 minute.
Okay, I am almost finished. Continuous assurance and support to the healthcare team to prevent burnout. So I conclude by telling that the basic goal is to support the healthcare facilities and protect patients from severe post-operative complications that contribute to high mortality, and protect healthcare workers from potential contamination. Thanks.
Thank you, Dr. Ashish. I think you have touched a very salient points. I will reserve my comments. First, I will go to the next lecture, The Practice of Cardiac Anesthesia in Pediatrics by Dr. Chandan Mondal.
Dr. Ashish, you need to stop sharing your screen. Thank you.
Yeah, okay.
Dr. Chandan, can you start sharing the screen?
Yes. My screen visible?
Yeah,
hello?
Yeah, you
okay.
are visible. Your screen is sharing. Yes,
okay.
We can see the screen.
Yeah. So in continuation with the previous topic, just I'm starting my talk, the practice of pediatric cardiac anesthesia amidst the COVID crisis. So basically, we all know the WHO infection control protocol. We have to maintain the standard precaution, contact precaution, droplet precaution, and airborne precaution. So I will start from the pre-anesthesia checkup for the child. So in pre-anesthesia checkup, we should do the RT-PCR or TrueNAT for the guardian and child within the 72 hours of the date of hospital admission, and RT-PCR or TrueNAT for child within the 48 hours of the scheduled OT. Now, in the pre-anesthesia direction, we should do we should put a intervenous channel before shifting to OT to avoid the mask ventilation while putting the IV channel inside the OT. Because you know, when we put the IV channel under the sedation, sometimes patients become apneic, then we have to start the mask ventilation. So to avoid that, we should put an intravenous line beforehand. And we maintain the same pre-anesthetic medication for COVID suspected child. Now, coming to the anesthesia part, place all the equipment and drugs in a tray and avoid handling the drug trolley during the intubation. Second point, place one high quality heat and moisture exchange filter between the tracheal tube and the breathing circuit, which Ashish already mentioned, and place another viral filter between the expiratory limb and the anesthesia machine, and standard routine anesthesia monitoring to be instituted. Now, use a HMEF with the acceptable dead space in a airway for the humidification. Available devices typically have a dead space of 10 ml and a minimum tidal volume of 30 ml for a 5 kg patient. So you have to be very careful about this HME and viral filter. And place a viral filter at the end of the expiratory limb with a virus filtration efficacy of more than 99%. So this is the thing, one from the patient to the tubing, another from the expiratory limb to machine. So anesthesia management, particularly for the child, the choice of induction agent, midazolam, fentanyl for analgesia, rocodinum 1 to 1.5 mg per kg, or succinylcholine 1 to 1.5 to 2 mg kg for tracheal intubation. Rapid sequence induction to be done in first attempt, and ensure adequate neuromuscular blockade to avoid bucking that can increase the aerosolization. Immediately inflate the cuff before starting the ventilation. Now, from all practical point of view, we all know the first attempt in a child, normally, if we are very lucky, we can put a adequately sized ET tube. But what happens, sometimes it happens either it could be a undersized tube or a oversized tube. So sometimes we need to back ventilation. So to avoid this manual ventilation, if it is required, apply small tidal volume, high rate, small tidal volume. That is the key. Now coming to the next step, reseat the laryngoscopy blade immediately post intubation with our outer gloves worn by the operator. Use low tidal volume and a closed circuit. Closed airway suction system preferable. If not available, then minimum number of suction. Now, normally, definitely my next speaker would tell about the management of the TE. So normally in the COVID patients, we avoid the pre-CPB TE if it is not very necessary. We coordinate with the pediatric team, and if they say that please there might be a additional VSG or like that, then sometimes we do a pre-CPB TE. Otherwise, we avoid the pre-CPB TE examination. So T after the coming of CPB, consider all T as aerosol generating procedures. Airborne precautions should be taken, minimize exam time, and standard approach. So what precautions we should take before after this T exam, after CPB T exam? Minimize exam time, minimize personal protective barriers, PPE for all the vicinity, and dedicated equipment. So don't PPE for airborne precaution measures, then gown, face shield, goggles, double gloves. Consider covering the ultrasound sheath like a knob screen with a plastic barrier, including the transducer port. Then during procedure, consider using video laryngoscope or direct laryngoscopy to limit the contact with the patient secretion, limit examination time by performing a focused exam, remove outer gloves and wipe inner gloves with the approved bicidial wipes, avoid unnecessary contamination of the touchable surface of the ultrasound system. And after the procedure, remove the T probe from the patient, wipe outer gloves, gown, sleeves with approved bicidial wipes, wipe down the equipment, remove outer glove, remove equipment and the probe container, then doff PPE. Now, extubation protocol either inside the OT like simple ASD or in ITU, there should be extubation protocol. So prophylactic antiemetic should be given, adequate pain management like fentanyl should be given, antitussive drug like remifentanil, dexmedetomidine or lidocaine can be given, position of the patient 30-degree head up, and extubation with a transparent water resistant plastic sheet. And in continuation, put surgical mask just after extubation and then put oxygen mask over it. Try to avoid non-invasive ventilation or nebulization just after extubation, extubation after proper donning, and avoid open suctioning, and if needed, closed suctioning should be used. So transport protocol for the intubated patient. Suppose if the patient is a RAX 2 or like VSD3 or RAX 3 and 4, we should transport the patient to the ITU. So keep the high quality HME viral filter attached to the ET tube all the time. Clamp the ET tube whenever ET tube is disconnected from the HME viral filter to maintain the closed system. Better to transport to the transport ICU ventilator. If not available, then single-use ambu bag attached with the HME viral filter with low tidal volume during the transport of patient. And patient should be adequately paralyzed to the neuromuscular blocking agent. Patient should be transferred through the designated corridor, designated lift to the designated ITU, proper running before transferring the patient. Thank you.
Thank you, Dr. Chandan. You have highlighted very salient points, the specific points regarding the pediatric cardiac anesthesia from pre-op, pre-anesthesia checkup, induction, till the transport to extubation.
Yeah.
Now I request Dr. Debashish Panigrahi to deliver his lecture for 5 minutes regarding the cardiopulmonary resuscitation. Dr. Debashish Panigrahi, can you share your screen, please? Dr. Chandan, can you stop sharing your screen?
Yeah, yes.
Good evening, everybody. Am I audible?
Yes, Debashish, you are audible.
Okay. So my topic of discussion today will be CPR in COVID-19 times.
Just talk webinare.
Chandan, can you unmute yourself? Chandan, can you unmute yourself? Mute yourself, not unmute, sorry.
Okay. So CPR in COVID-19 times. So as we all know, it's been a rough 1 year for all of us. So what we know about this COVID-19 virus, this is a highly contagious, highly transmissible virus, particularly during resuscitation. Why during resuscitation? Because resuscitation is an active aerosol generating procedure because of involvement of chest compression, back mask ventilation, placement of an advanced airway, many people working in close contact with each other in an emergency situation. So we have to be careful so as to not infect ourselves, the healthcare workers, because already there is a strain to the healthcare system because of the less number of healthcare workers. So if we infect ourselves, that becomes further jeopardy to the already strained system. So we, the healthcare workers, have to balance the immediate needs of the patient with their own safety. So what we know, the older patients with comorbidities like diabetes mellitus, cardiac disease, hepatic impairment, renal impairment, respiratory pathologies, or immune impairing conditions that are more vulnerable and have higher mortality from COVID-19. 12 to 19% of the patient population infected with COVID-19 require hospitalization, and 3 to 6% develop critical illness requiring ICU or SDU care. So, what happens? Why there is a situation of cardiac arrest requiring CPCR? The major factors are hypoxemic respiratory failure, secondary to ARDS, as a myocardial injury, as a ventricular arrhythmias, and shock, both distributive and cardiogenic. They're all common among critical ill patients and predispose them to cardiac arrest. So there becomes a need for some adjustments into the existing CPR protocols by the AHA because of this infectivity of this virus, highly infective situation, so as to prevent further dissemination of infection among the healthcare workers and other patients in the hospital. Because of the limitation of time, I'll be discussing only in-hospital cardiac arrest. So what are the adjustments that has been proposed to the existing recommendations? So it has been discussed in 3 headings. First is reduce the provider exposure. That's the healthcare workers or the EMS personnel, emergency medical personnel. Done the PPE, the personal protective equipment, before entering the room or scene. The PPE donning and this PPE thing depends on the hospital protocol and it also depends on the availability of the entire PPE. What has been recommended is a coverall, entire gown, N95 respirator, face shield, goggles, sterile gloves, etc. But we know that every time everything might not be available in all the places. So it has to be decided by the hospital as per their availability. Limit personnel. Make a triangle of provider healthcare. The person one who is well versed with airway manipulation should lead, and there are other two persons working in tandem with the chest compression and defibrillation or giving essential medications. Consider using mechanical CPR devices for adults and adolescents who meet height and weight criteria whenever it's available. This all things are to reduce contact of healthcare personnel to the patient and communicate with any new provider that is coming into the scene. That's the COVID-19 status of the patient. All these things should ideally be done in a negative pressure room, but we all know that the number of negative pressure rooms across the globe has fallen short because of unprecedented course of the disease of this virus affecting population. So it's being done anywhere now. It's not, doesn't matter whether it's a negative pressure room or not. Next, to prioritize the oxygenation and ventilation strategies with lower aerosolization risk, use high efficiency particulate air filter, that is a HEPA filter with a viral filtration ability of 99.9% if available for all ventilation. This is a very important step. So if available is written because of say availability, but it should be done. Intubate early with a cuff tube if possible, and connect to the mechanical ventilation when able to engage the intubator with highest chance of first pass success. See, if there is a chance that a person who is on the scene and he or she is not a very expert manipulator of the airway, so it's better to wait for to arrive somebody with a better expertise with the airway and provide hands-on only CPR without any further try to put a endotracheal tube or a LMA supraglottic airway. Don't do that. Just give hands-on CPR with a supplemental nasal oxygen. Put a mask over the face of the patient so as to not to cause further dissemination of virus into the atmosphere. Just do CPR. Wait for somebody with the expertise to arrive. So when the person is trying to intubate, put pause on the chest compression. This is again to avoid dissemination of the viral particles. These viral particles, once disseminated by aerosol into the atmosphere, is a half-life of around 1 hour. So there is high chance that other persons will get infected if we are not careful enough. Consider using a video laryngoscopy if available, and if the there is expertise with the user, because it also has a say practice is a thing. So before intubation, use a back mask device with a HEPA filter and tight seal. So many a times for short duration, we can use oxygen through the nasal cannula, put a mask, do the CPR. For brief period, we can do that. But if it extends for some time, then that doesn't hold good. Or even it's a pediatric patient. So we have to use back mask ventilation, then use a HEPA filter and put a tight seal with both hands. That has been recommended for back mask ventilation before putting a advanced airway equipment. So for adults, again, this passive oxygenation, non-breathing face mask.
Debashish, your 5 minutes are over. Have a grace minute of 1 minute.
Okay. So if intubation is delayed, consider supraglottic airway. Minimize closed circuit disconnection. Once there is a placement of advanced airway, connect with the ventilator with the HEPA filter and another viral filter of the expiratory limb, and do not disconnect. Do not try. This is the old recommendation that holds still good. Only few things in the yellow boxes, done PP and prioritize intubation and resume CPR, have been added. One other thing in the reversible causes we can see here, H, hypovolemia, hypoxia, etc. One thing, in a patient who have been prescribed HCQS along with azithromycin, there are chances of hypomagnesemia leading to long QD syndrome and dorsal D points. So their hypomagnesemia can be treated with magnesium sulfate 1 to 2 grams slowly in the reversible causes. Then coming to the take home points, protect yourself before starting chest compression. So P before CAB, secure airway to minimize exposure risk, restrict team composition, practice additional care while placement of tracheal tube like face shield, attach ventilator early, preferably use an AED if defibrillator pads are available. Okay. The seventh H, like the hypomagnesemia, leading to Torsades points. And CPR can be given in prone position without advanced airway in place, but the the evidence is scarce. Early use of vasoactive drugs instead of aggressive fluid resuscitation in patients of reversal of spontaneous rhythm circulation, and consider the appropriateness of the starting and the duration of CPR because of the limited resources available to us at this point of time. That's all. Thank you.
Thank you, Dr. Devashish. I think in this session, starting from Dr. Ashish, then to Dr. Chandan and Dr. Devashish, they have enumerated the salient points of practice of cardiac anesthesia for adults, followed by pediatrics and cardiopulmonary resuscitation, and starting from the pre-anesthesia checkup to the induction, maintenance, extubation, and the transport of the patient. One thing I just wanted to add during this presentation, my comment, is ACA guidelines also an updated regarding one salient features of the extubation, apart from what Dr. Chandan told and what Dr. Ashish told, is that if you extubate the patient, whether a COVID positive patient or a suspected patient in the operation theater or in the intensive care unit, there is a mask over tube strategy specifically for COVID patient. What is that? Specifically, this is for adult, that when the cuffed endotracheal tube during the extubation is pushed or moved towards the angle of the mouth right side and place a bag, mask and a filter over it and seal, that the mask is sealing over the endotracheal tube. Then by a two-hand technique, deflate the cuff and this tracheal tube is connected with a filter, HMEF filter with a breathing circuit. In toto, you have to extubate that patient with a mask over the tube. And after extubation, you put the second filter over the first filter. So this is an added precautionary measure which ASA guidelines have included in the month of September and October, and which is followed in most of the units when you are extubating a patient, whether in intensive care area or in operation theater, a COVID suspected or COVID positive patients. Otherwise, I think all the points have been clearly enumerated by all three of them.
Thank you, Dr. Shoibal, for excellently moderating the session, and thanks goes to all our speakers, Dr. Ashish, Dr. Chandan, and Dr. Devashish, for giving a very comprehensive idea and knowledge about cardiac anesthesia in COVID times. We'll go to our next session, which is a very relevant session of peri-operative echocardiography in times of COVID. And do we have Dr. Devika? Yes. Hi, Dr. Devika, welcome.
Oh, Rahul, hi. Good afternoon.
Very good afternoon, Dr. Devika. Dr. Devika Chatterjee is a senior consultant non-invasive cardiologist and the head of the Department of Echocardiography at Ravindranath Tagore International Institute of Cardiac Sciences. And the speaker is Dr. Shomi Dash, our scientific secretary of IACTA West Bengal. Dr. Shomi is the associate professor of the Department of Cardiac Anesthesia at Institute of Postgraduate Medical Education and Research, Kolkata. I will request Dr. Devika to invite Dr. Shomi to give the talk.
Yeah, hello, good afternoon, everybody. So this COVID-19 infection has led to the devastating loss of human life, created an unprecedented disruption to our routine medical practice, which includes the echocardiography. We cannot conduct the echocardiography in the usual way because if we conduct in the usual way, we are at a higher risk of infection. So we have to do, and again, we have to take certain precautionary measures. So while doing this, we face challenges, and peri-operative echo is such an important subject of echocardiography, and we are doing it every day, 100 times we are doing it, but again we are facing challenges. So here is Dr. Shomi Das, who is associate professor of anesthesia in SSKM, is going to speak to us on the challenges during peri-operative echocardiography in the COVID time. Dr. Shomi, please.
Thank you,
Dr.
ma'am.
Shomi, you have 10 minutes for the presentation.
Just a minute. Dr. Verma, will you be able to please share the my presentation, because I have a technical snag here?
Yes, just a minute.
Yes, yeah.
Yes, we can see it.
Yeah, thank you. Thank you. So I'll move ahead with my presentation. I hope I'm audible. Provision of echocardiography services remaining crucial during this pandemic scenario. In order to minimize risk to staff, the American Society of Echocardiography has published statement with recommendations to improve safety and reduce the potential for cross-contamination. The parent statement of recommendations approved by AAC Executive Committee in March 2020 has undergone 3 revisions since then with additional information. Today, the focus of this talk is primarily on specific considerations for the protection of patients and echocardiography service providers when performing perioperative or periprocedural transesophageal echocardiography during the 2019 novel coronavirus outbreak. Please change the slide. So the highlights of this article highlighted that transesophageal echocardiography carries a heightened risk of transmission of SARS CoV2. TEE should be performed only when clinical benefits outweigh risk. Proper handling and cleaning of equipment is critical. Airborne precautions should be used in patients with suspected or confirmed COVID, and considering the 3 pertinent questions as to whom to image, where to image, and how to image has the potential to reduce transmission risk. Please change the slide. The slide has to be changed. So coming to whom to image. Now the risk of TEE in non-intubated patients is greater. So alternative imaging modalities like off-axis transthoracic echocardiography or use of ultrasound enhancing agents can be considered. TEE should be performed in intubated patients only in perioperative settings in which benefits outweigh the risk. Non-essential TEE should be postponed or deferred in confirmed or under investigation COVID patients, except for in certain clinical situations like urgent or emergent cardiac surgery, patients with cardiac comorbidities undergoing non-cardiac surgery, and hemodynamic instability due to undifferentiated shock during the perioperative period. Please change the slide. So triaging of patients for TEE, for patients undergoing cardiac surgery is to be considered. TEE is considered essential in certain surgical procedures in which benefit outweighs the risk, like infective endocarditis with valvular and perivalvular involvement, Stanford type A aortic dissection, initiation of temporary or durable mechanical circulatory support, myocardial infarction with mechanical complications, and prosthetic valve assessment. Change the slide, please. In some surgical procedures in which TEE can be replaced by other imaging modalities, TEE can be averted, like with the use of fluoroscopy or epicardial imaging, or in certain surgeries like as in CABG or Stanford type B aortic dissection, a direct visualization of the surgical field would be enough, except for when there is a severe hemodynamic instability or procedural complication, when we might have to shift to TEE. So this article suggests an algorithm for determining the indication of intraoperative TEE, most of which we have already discussed. Change the slide, please. Coming to where to image. So perioperative TEE, the next slide, please. The next slide, please. We have to move to the next slide. Yeah, thank you. So coming to where to image. Perioperative TEE can be performed in operation theaters, structural heart and catheterization lab rooms or ICUs. Patients with suspected or confirmed COVID-19 should undergo surgical or interventional procedures only in dedicated COVID-19 operation theaters. Change the slide, please. So coming to the relevant question of how do we go about with performing the TEE? Abbreviated and pathology-directed protocol should be considered for TEE in suspected or confirmed COVID-19 to limit personnel exposure time. Protection of personnel would include drop-it precaution for TEE in patients without COVID-19, and airborne precaution for all high-risk patients. Protocol for protection of equipment should be followed to prevent cross-contamination. As per the parent article by AAC on protection of patients and eco-service providers during a novel corona outbreak, the type of PPE would depend on level of protection used as per indication. For example, standard care involves hand washing or hand sanitization and use of gloves. Use of surgical face mask can also be considered. Droplet precautions include gown, gloves, head cover, face mask, and eye shield. Airborne precautions add special masks like N95 or N99 respirator masks, powered air purifying respirator systems, and shoe covers. The next slide, please. The same article, there is a suggested algorithm for determining indication and level of protection, which we have already discussed. For example, first we consider whether the echo is indicated at this time. If yes, we see whether the patient is a suspect or confirmed COVID-19. If yes, all TEE procedures should be performed under airborne precautions. And if it's a no, then standard precautions or droplet precautions can be considered for while performing TEE. Next slide, please. Guidelines of cleaning, disinfection, and protection of ultrasound equipment and probes can be found in the official statement by the American Association of Ultrasound in Medicine, or AIUM, which has been updated with special considerations for COVID outbreak, which include for external and interventional procedures, low-level disinfection is effective as per CDC guidelines. If low-level disinfection agents are depleted, then soap and water can be replaced, can be used instead. If there is no transducer cover, then medical gloves can be used. All ancillary equipment are to be cleaned. And in case of aerosol generating procedures in COVID-19 patients, a transducer cover should be used, and the entire equipment requires a full low-level disinfection. Next slide, please. So this is an online site by the Environmental Protection Agency, or the EPA, where we can find the list end tool for COVID-19 disinfectants, where one can search for EPA approved COVID-19 disinfectant agents and their use, including the contact time. Next slide. We can see here that the USG console, including the screen, the keyboard, the transducer ports, have been covered with disposable plastic. A screen can be used between the patient and their transthoracic echocardiographer to prevent transmission and to ensure safety.
Dr. Shomi, you have 1 more minute.
Okay. So the article also suggests a stepwise algorithm for performing TEE in patients with suspected or confirmed COVID-19. The AAC has also published specific considerations for pediatric, fetal, and congenital heart disease patients and eco-service providers during 2019 novel corona outbreak. So this article suggests that PCHD echo providers are at increased risk of exposure to SARS CoV2 unknowingly. Indication for echo in PCHD population differs from adults, guided by appropriate use criteria as given by AAC and other societies. Traditional transthoracic echocardiography is preferred over point-of-care ultrasound. Protection measures, higher level PPE should be used. And in all patients in whom TEE is planned, SARS CoV2 testing is performed during the pre-operative screening. Next slide. You have to move. The next slide, please. And the next. The next slide. Yeah, thank you.
Dr. Shomi, your time is up.
Yeah. So I'll take 1 more minute. The AAC has also come out with a statement on reintroduction of eco-services during the COVID-19 pandemic. As the pandemic unfolded, many non-urgent eco studies were referred in an attempt to reduce coronavirus transmission among patients and healthcare workers, to conserve PPE and prepare for potential surge of patients with COVID-19. Although COVID-19 prevalence and new case trends continue to differ substantially by region, many facilities are now planning resumption of non-urgent and elective medical services. So the North American, so the North American cardiovascular societies have proposed a level of response for reintroduction of services. Level 2, the initial phase of response is reintroduction of select services. In level 1, reintroduces most services with appropriate precautions and safeguards in place. Level 0, provision of all routine services with ongoing COVID testing and surveillance with monitoring of PPE. The article also suggests a prioritization tier for rescheduling eco-services. If one is interested, one can go through. With the reintroduction of eco-services, the article suggests some changes in protocol as per level of response. You have to move to the next slide. The next slide. Yeah. So comprehensive 2D eco is now rather preferred over the focused protocol. The level of PPE use will depend on the level of response. COVID-19 symptom screening for all patients at multiple time points at all response levels is recommended. Echo should be deferred in all COVID-19 positive patients when possible. Special considerations for pediatric echo lab would include a higher level PPE use, and special consideration would be a pediatric echocardiographers should be aware of the new troubling presentation of COVID-19, that of pediatric multisystem inflammatory syndrome. All such children should be treated as COVID positive irrespective of test result with use of high level of PPE and N95 masks. Thank you for the patient hearing, and sorry for the technical problem.
Thank you, Dr. Shomi. I would request Dr. Devika to give a very short sum up on the current scenario of echocardiography.
Yeah, thank you, Rahul. Shomi, it was a beautiful presentation, but I think there was a time problem because of your technical problem. But it was an excellent presentation. The challenges which we are facing while doing transesophageal echocardiography in non-intubated patient, I'm telling you a practical problem. The patient starts coughing, even if we sedate with midazolam and propofol, while the probe is inside and patient starts coughing. That is a challenge. Like what you are going to do now. Patient starts coughing and you are exposed. So what is my suggestion, that always we have to keep our guards on, like always with double mask, N95 or preferably N99 with a surgical mask on top of it, and a face shield, and also double gloves. These are very, very essential during transesophageal echocardiography. While doing transthoracic perioperative procedures, I think we should keep equal amount of guard. Maybe we can avoid the surgical mask on top of N95 and a single gloves. However, we have to take all the precautions. So that way we are facing numbers are increasing gradually, and the number which has gone down to 50 to 90% has now recovered almost 80 to 90%. So we have to keep our guards on. So that's all is my message. It was a very nice. You have to say anything for Shomi?
Thank you, Dr. Devika, and thanks, Shomi. We are currently constrained by the time. Thank you both for a wonderful session. We will move to the next session, which is another very important area of anesthesia during COVID because of the challenges of aerosol generation. And we are deeply honored to have Dr. Thomas Koshi with us. He needs no introduction in cardiac anesthesia circles. Dr. Koshi is a very senior cardiac anesthesiologist, currently the professor and head of the Department of Anesthesiology at Sri Chitra Institute of Medical Sciences, Trivandrum. And today the presentation will be done by Dr. Dibyendu Khan, who is a consultant cardiac anesthesiologist at Apollo Gleneagles, Kolkata. Dr. Koshi, if you can ask Dr. Dibyendu to start the presentation.
Okay, thank you, Rahul, for that wonderful introduction. As the outset, I want to say that we have learned to live with COVID. We are no longer afraid of COVID, but we take precautions against COVID. So thanks for inviting, and I'm listening to the series of presentations, good presentations. So now we move over to how to manage a thoracic case. I invite Dr. Khan. He is working as a consultant in Apollo Hospital, Kolkata. So, ma'am, can you start your presentation?
Dr. Dibendu, if you can share your screen. Thank you. Dr. Dibendu, are you there? Yes, I think there was a broadband issue. Dibendu has just joined. So,
Okay.
Dr. Dibendu, please share your screen with all of us.
Yeah, hello. Sorry, there was a technical issue. I got logged off. Good evening, everybody. Rahulda, can I start?
Please, please go ahead with Dr. Koshi's permission. He has already asked you to start.
Okay. Thank you, sir, for the opportunity. Today's, I'd like to speak on, can you see the screen?
It's
starting.
Yeah.
And Dibendu, you have 15 minutes for the presentation.
Okay. This is, I'd like to speak on practice of thoracic anesthesia in this COVID crisis. And I wish everyone a very happy new year. And why we are more concerned about this, what is the specific about thoracic anesthesia in this COVID crisis is the main purpose is it's a potentially severe and highly contagious respiratory disease spread by the coronavirus, which is SARS COV2, and which is a family, it's a member of the family of single-stranded RNA virus. And mainly it's transmitted by the respiratory droplets and also by direct contact. Now, the most concerning thing for anesthesiologists and specifically thoracic is both symptomatic and asymptomatic patients can be infective. So that's one of the main concerns for us. So that's why it leads to our increased risk of exposure when we are dealing with this kind of any patients who are coming for thoracic surgery, because you are in direct contact with the trachea during intubation, when we're doing bronchoscopy or any airway suctioning procedures, either before, during, or after the one lung ventilation, which is required during thoracic surgery. And also even during extubation, also we are in direct contact with the trachea. And patients may present with varying degrees of respiratory infection. Now, different societies, when the COVID pandemic started, all of the different societies like World Federation Society of Anesthesiologists, Anesthesia Patient Safety Foundation, UK Societies, Canadian Society of Anesthesiologists, Task Force of Chinese Society Anesthesiologists, they formed, they already suggested different way how to manage the patients. Now, initially, the first thing which was formulated by was Difficult Airway Society and along with Association of Anesthesists, Intensive Care Society and Faculty of Intensive Care Medicine, they produced a protocol for management of airway in patients with SARS CoV2. Now, from there, the European Association of Cardiothoracic Anesthesiology formed a subspecialty committee, and they initially gave a preliminary recommendation using expert opinions and also by reviewing different clinical experience in patients with MERS COVID and also during COVID-19 undergoing thoracic surgery. They formulated different protocols. And I'd like to we'll focus on a few of these preparations and the recommendations which is required for their providing thoracic anesthesia, airway management, one lung ventilation, and what we do during extubation. Now, if you look into this table, most of the societies are actually having the similar kind of protocols regarding when we are talking about the main thing is about the team safety. Here, the one thing which has made this pandemic is till now, prior to pandemic, we were all mainly concerned as clinicians for patient safety. But after the pandemic has started, we need to think also for our own and the staff safety also who are involved along with the patients. So, so that's one of the concern which has come up. Now, organization aspect, team communication. Now, what are the principles we use during intubation, and also what are the protocols during what sort of instruments and extubation? Most of the protocols or recommendations were initially followed and were similar in different societies which were formulated initially. Now, the first thing for thoracic surgery patients who are coming, it's better to have a pre-operative screening by doing a COVID-19 amnestic questionnaire. The most common thing we should ask is whether the patient had any contact with COVID-19 case in the last 14 days, with the presence of any symptoms like fever, cough, sore throat, burning eyes, or widespread pain, breathlessness, asthenia, or diarrhea. Any patient is coming from a high-risk area where predominantly a lot of COVID cases have been found, or any family members with symptoms. Now, if all these responses were negative to the questionnaire, then and obviously the blood and chest X-ray were normal, then we go ahead and perform the surgery. Now, on the basis of questionnaire, if we have a doubt or there were any positive responses, we obviously proceed for a RT-PCR, the microbiological testing. And if test is positive, then obviously we like to postpone the surgery. Or if the CT scan is also suggestive of lesions which is pertinent to COVID-19, we should try to postpone the surgery as much as possible. But obviously, keeping in mind, if the patient is coming for an emergency surgery, we need to take adequate precautions, which I will be dealing. Now, what do we do during tracheal intubation? There is a lot of risk of aerosol generation is there during the placement of the airway device. And when we do bronchoscopic check for placement of one lung ventilation, which is required during thoracic surgery. And this risk for this kind of patients with severe COVID-19, we need to highlight the thing is they don't tolerate longer periods of apnea. So inadequate oxygenation is in case of failed or delayed tracheal intubation, it's a big problem for this kind of patients. Now, what we do is during the intubation, it has to be safe for both patient and the staff. It has to be accurate, that is avoiding unreliable or unfamiliar or repeated techniques. And it has to be swiftly done within very fast without any rush or any delay. So now all the senior people or the expertise is required for procedures when we do thoracic anesthesia. Now, why we are concerned about asymptomatic patients in patients who are posted for thoracic surgery? They may also have the viral infection during this pandemic. They have the potential contagiosity, though there is a false negative test cannot be excluded with certainty. And team has to be very cautious with every patient, and we should take a cautious approach. And we should done for every thoracic surgery, as we do in our institute, we should consider every patient as a potential positive for infection and take adequate precautions. Now, where do we location for the intubation? It's preferred as per recommendation is isolated negative pressure room with more than 12 air changes per minute. But if not available, we should have a proper PPE. Obviously, clinicians who are performing the procedure should be increased, like respirators in place of mask, face shield, and helmet. And intubation should be performed in a negative pressure room, followed by transfer to the OR. Now, if there is no negative pressure room available in rooms with positive ORs with positive pressure, room should be put under least possible positive pressure if possible, and the remainder of the unit under higher positive pressure. And doors should be kept closed, and there should be a high exchange rate of air in the room, which limits the dispersion of aerosols outside the room during the procedure. Now, who are the medical staff to be involved? We should not try to exclude practitioners who are significantly vulnerable. So older age, more than 60 years, immunosuppressant, or pregnant clinicians who are pregnant, or any patients, clinicians who are having serious chronic comorbidities should be avoiding doing these procedures. Now, inside the room, like where we're doing the main procedure like tracheal intubation and bronchoscopy, there should be, which we call as the red zone, there should be at least 2 attendants. And intubation should be performed by the most experienced physician to minimize any delay or related complications. And the second doctor should help to administer drug and monitor the patient in case of any unanticipated difficulty. Now, there is something called, they have done a runner physician, or we can say also a runner OT technician should be available just outside the room with a full don PP in case of need for any help. And outside the dedicated OR, an observer must be also present to monitor the adequate donning and doffing process in the whole during the whole procedure. Now, when the procedure has been done, the surgical team, the anesthesia, the rest of the anesthesia team, the nursing and the paramedical staff need not be inside the OR until the airway has been well secured to minimize the risk of transmission. Now, what are the airborne level precautions? We should have a proper hair covers or hoods, fitted filtering face piece like 3 or N95 or fitted face piece 2 mask, goggles or face shield should be worn, long sleeve fluid resistant gown, double gloves and overshoes has to be there. Now, this is what donning and doffing has been done, which has already been dealt. Now, preparation, there should be available of disposable devices like single-use blades or laryngoscope. Video laryngoscope is the preferred one as per the Difficult Airway Society has suggested, with remote screens, and also with flexible bronchoscope with remote screen. Now, the highlighting things also is we should use a closed system for suction. There should be an anti-fogging material, and obviously we have to make sure the double lumen size tubes which we are planning to use, at least one size higher and one size lower to the estimated size should be available. And in our center, like if you're using a bronchial blockers, there should be availability of that where we are using bronchial blockers. Now, this is just a nutshell how the things are to be kept and what are the things to be kept ready in a intubation trolley and how do we prepare the OT. Now, before intubation, there should be a proper evaluation or re-evaluation even after a PAC has been done. Patient's position should be rechecked with 45-degree head up sniffing position. Adequate oxygenation and hemodynamic status should be well maintained. There should be a standard routine monitoring should be done. Continuous waveform capnography is done, and breathing circuit should be well checked, and application of antiviral filters both in the patient end and in the machine end is to be applied. Now, how do we pre-oxygenate these kind of patients with COVID-19 who are coming for thoracic surgery? As I already mentioned, that in these patients, the risk of hypoxia or they don't tolerate prolonged apneic, so a pre-oxygenation is very much required. So using 100% FiO2, either 3 minutes of tidal volume or good breaths during the minute at forced vital capacity, or we can also give with CPAP or pressure support ventilation of 10 centimeter water or PEEP of 5 for 3 to 5 minutes is required. Now, if at all bag mask ventilation is required, 2% technique with a low flow and low pressure is recommended. Now, the crucial thing about here is we need to decrease the need for mask ventilation before securing the airway. Now, if at all we need to give face mask ventilation, most often we try to avoid because the recommendation is for rapid sequence induction. Otherwise, if it is required, we should go for a 2% low flow, low pressure technique and a 2% two-handed mask ventilation technique. Now, induction, we prefer for rapid sequence in all. Hypnosis and analgesia, it better to use ketamine 1.5 to 2 milligram per kg or appropriate doses of propofol and opioid. Neuromuscular blockade, around we use rocuronium 1.2 milligram per kg or succinylcholine around 1.5 mg per kg. Now, if we are proceeding for lung separation or lung isolation is required, if it's already the patient is intubated and we are bringing the patient from ICU or COVID ward, then for a female patient, most likely better to have a higher size ET tube because for providing a bronchoscope and along with bronchial blocker, it will be better. So 7.5 or 8 size tube for a female patients and for 8 to 9 size tube for male patients. And then we should proceed for the bronchoscopy and confirmation of the bronchial blocker insertion. If not, then adequate pre-oxygenation is done. Now, this is just how tracheal intubation. This is by a nutshell given by a Difficult Airway Society. So for an anticipated or an unanticipated difficult airway or a predicted or known difficult airway, what we should do. So if there is a known or difficult airway, we should go for an awake intubation if needed. There should not be any topicalization. They should try to sedate and then try to go ahead with the procedure because aerosolization, to limit aerosolization of the procedure, we should avoid giving aerosols like lignocaine nebulization and all pre-procedure for awake intubation. Now, if we succeed with intubation, then we can proceed and we confirm either with a double lumen tube or a bronchial blocker. Double lumen tube in this kind of patients can be first intubated with an ET tube, and then with a tube exchanger, we can railroad a double lumen tube. Now, if we fail, then we should proceed for a surgical tracheostomy or we abandon the procedure. For an unanticipated difficult airway, the pathway would be a rapid sequence induction with a video laryngoscope, preferably a single-use blade and remote screen. And if it is succeeded, that's well enough. We proceed either with an ET tube with a bronchial blocker or a double lumen tube. Or if it's failed, we try for again second attempt after adequate again pre-oxygenation with a low tidal volume and low pressure technique. Still it fails after the second attempt. We should again go ahead with a pre-oxygenation with a supraclotic device. And even if the third attempt is failed, even with a supraclotic device, we should either proceed for surgical tracheostomy or we should abandon the procedure. Now,
Dr. Dibendu, we have 1 more minute.
Okay. So the tracheal intubation and lung separation, there are a lot of guidelines which has been sold. The main highlighting thing is it should be deferred. If the patient is non-urgent surgery, it should be deferred. A dedicated negative pressure theater, if feasible, is recommended. Plan ahead and communicate. Use of adequate PPE. There should be a closed suctioning system and use of antiviral filter. Be prepared for treating the hypoxia. Now, these are the few absolute indications which I don't want to repeat. Now, after the intubation, an NG tube has to be placed, a closed suction system has to be used, and reusable equipment should be placed inside the sheaths immediately and decontaminated after tracheal intubation. Doffing should be performed and monitored by an observer. And if the intubation room is separate to OR, this room should be cleaned for 20 minutes after intubation. This is how we fix up an HEPA filter in the circuit. And this is what we do regularly for our unit. When we do a bronchial blocker insertion, we use a protective transparent drape during bronchoscopy using a remote screen. And we use also an antiviral filter in a DLT. This is how it has to be placed when along with the antiviral filter, which is attached to the bronchial lumen. And recommendation for conduct of one lung ventilation need not be mentioned, as we all know. And for use of CPAP in a bronchial blocker, what we do in our OT is we need to attach a antiviral filter also along with the CPAP to give into the CPAP connector to the tip of the bronchial blocker. And tracheal extubation, it should be well done with a closed suction system. And the main thing is the extubation should be done to face mask, which has already been dealt, and be ready for again re-intubation. And after extubation, the breathing circuit should be changed. The circuit and the soda lime canister should be decontaminated. And for a next procedure, a waiting period of 20 minutes with the necessary disinfectant with 3 to 5% chlorine solution is required. Post-operative management and patient transfer should not be taken to common areas. They should be delivered oxygen wearing a surgical face mask, and nasal cannula is preferred. And if you have to transfer this patient to ICU, the healthcare workers should wear adequate PPE, and they should avoid unnecessary disconnection, and security team should be well aware to lead and guarantee clearance of bystanders during the transfer of the patient. So these are a nutshell again of the peri-operative recommendations. And this is what the references from the recent guidelines by thoracic anesthesia of the European Society. Thank you.
Thank you, Dr. Divendu. Dr. Koshi, if you can give a short summation of the session.
Yeah, Dr. Divendu has very smoothly presented all aspects of managing a thoracic anesthesia, in a COVID. Very smooth, and you touched every aspect of it. But my one question to if the patient is RT-PCR negative, he doesn't have symptoms, do you observe all this?
What is that? If the patient is RT-PCR
negative,
yes, sir,
and there are no symptoms, and okay. Do you want to manage like this? I mean, the question I am asking: is there a need for rapid sequencing detection? Is there a need for using rocuronium?
At present, in this pandemic, I think we should prefer to use a adequate precaution. Still, even if the patient is RT-PCR negative and asymptomatic.
I mean, okay, we are bold because in cardiac surgery here we check every patient RT-PCR and negative. We do like routine only.
Yeah, we are doing in our institute also, sir. All the patients coming for surgery RT-PCR. So even if it's negative, I think we should take adequate precaution because of the asymptomatic group of patients who may still have the.
Okay.
Or even because we had a group of patients. We had one patient who was negative, who was posted for a minimal invasive cardiac surgery and was shifted from cath lab. So patient was there in cardiac ICU for 2 days, and then the patient was posted for. So RT-PCR was done pre-angiography. So that was 4 days prior to the procedure, main procedure, CABG, and she was negative. But post-op, she had developed symptoms and turned out to be positive. And so I think some patients may have.
Okay, we are being extra cautious, so that is always better.
So if we manage to get adequate, even if PPE should not, I would say that we don't use PP as such, we just we make sure double gown, cover of make a hood, and obviously shoe covers is at least mandatory for going ahead for a thoracic surgery case.
Okay, good. See, our level of precautions are steadily coming down. Now, we initially used this surgical gown, then it became N95 and face shield. Now people are not using face shield also if the RT-PCR is negative. So now our precaution is only N95, nothing more than that. If the RT-PCR negative. If the RT-PCR positive, then of course PPE. That is our practice, I'm telling. But everybody should. This is not a recommendation. This is what we do. But definitely, I agree with your suggestions. And Rahul, you have any suggestion? I hope Rahul is listening.
Yes, yes, Dr. Koshi, I tend to agree with you as the pandemic is progressing and we have had a huge experience with patients in the theatre. I also believe that N95 is the single most precaution that one should take when the RT-PCR or TrueNat is negative, and maybe wear just a kind of a face shield over that or eye protection. And but for COVID positive patients, absolutely the full PPE is warranted. Great. Okay. Thank you, Dr. Koshi, and thank you, Dibendu, for a wonderful presentation and a wonderful moderation. We are running a little late and we have so many other interesting sessions coming up. So we will go ahead with the next session, which is coming. Dr. Dibendu, if you can stop sharing your screen. Dr. Suresh Rao is here with us. Again, Dr. Suresh Rao needs no introduction in cardiac anesthesia circles. Me and Dr. Suresh will be moderating the next session on ECMO. Dr. Suresh Rao is the Senior Consultant and Chief of Cardiac Anesthesia at MGM Hospitals, Chennai. Welcome, Dr. Suresh, to IACTA West Bengal session. And we have two excellent presenters today who will be presenting their data for ECMO in COVID. The first speaker is Dr. Murli Krishna, who is a Senior Consultant Cardiac Anesthetist in MGM Hospital from Dr. Suresh Rao's hospital. He will be giving his experience from the southern India. And then from the east, Dr. Orpon Chakraborty, who is a Senior Consultant Cardiac Anesthesiologist in Medica Hospitals, Kolkata, will be sharing his experience. So without wasting any further time, can I invite Dr. Murli to present his data?
Good afternoon, everyone. Are you able to see my screen?
Yes, absolutely.
Oh, sure. Thank you. I'll go ahead. I'm Dr. Murli from MGM Healthcare. I would like to thank the organizers for giving me this opportunity. For the next briefly 8 minutes, I'd just like to briefly present about the ECMO for COVID and what we have seen over the last 6 months of this pandemic. So to start with, we'll look at briefly what are the indications for the ECMO in a COVID patient. In one simple word, it comes to resort, where you have exhausted all your options and not able to maintain gas exchange. Like you should have done prone ventilation, you should have followed all the ventilation protocols before you think of ECMO in these patients. There have been clear guidelines by the ELSO, but again, we have to tweak it according to our institutional practices or standards to get the better outcomes. So the standard ELSO guidelines is you start thinking about an ECMO in a COVID patient who is on ventilator only under these situations when you have a PF ratio of less than 60 persistently for 6 hours, or if you have a PF ratio of less than 50 for more than 3 hours. Along with it, or separately, if you have a carbon dioxide of more than 80, that is associated with a pH of less than 7.2. If your pH is neutral, then you won't worry about this for more than 6 hours. That is when you start thinking of this patient, whether he is for an ECMO or not. We go and review such patients. And if he is for an ECMO, then after the initial counseling, looking for any other issues about the patient, that's when you proceed for the ECMO in this patient. Before I go into our experience, I just like to present one slide that has been in the ELSO data or in the ELSO registry. As we see now, there have been quite a good enough data of close to 2,500 patients with the ELSO about how the ECMO is being faring in this COVID patients. What I would like to point out is two things. One, as we can see, the amount or the duration of the care that is needed for these patients is for prolonged time. We can see the data they have collected is close to 90 days. So we should be prepared to handle these patients for a long time. Then second, the outcomes are quite varied. Mortality being close to 40 to 50%, and good amount of them who are getting discharged are getting discharged with going to secondary centers where they need to continue the care, ventilator care or home care types of thing. So if you come at our institutional practice, when choosing a patient, we do get calls for a lot of cases who need to go ECMO. What we look at is typically age more than 65, we don't consider. 50 to 65, we look at how is the patient faring on other fronts and then take a decision. And the degree of lung involvement, typically by the time we see, the lung would have been extensively consolidated along with no other reversible causes like a pneumoeffusions or anything. Then we have to look at endocrine damage, sepsis or MOTS. If we are at a referral center, quite often we get calls, or more often the calls are for the patients who have already had other issues, like the sepsis would have progressed to an endocrine dysfunction or would have set in MOTS or would have had a hypoxic brain injury and all. These patients usually, unless it's an early reversible stage, we don't consider these cases. Then what we look at is it's an early referral or a late referral. When I use the word late referral is one who have crossed typically that 4 weeks mark after having the COVID positivity, where the chance of lung recovery may have come down and primarily they may be progressing towards a destroyed lung, that is either a fibrosis or cavity or bronchiectatic kind of lung. So quite a lot of them we got for the late referrals from across multiple places in the country. Early referrals are the one who have better outcomes. And as we have seen in the previous slide, whether these patients are for a long-term care or not from every aspect. If they're not for long-term care, then probably we should not consider in these patients. The common scenario of all of them, you get when they're on oxygen and they're desaturating, the sats are around 70, 80 with this. And all of them would have had multiple XDR bugs by the time you see the patient or you find out about the patient first with septic attacks, probably organ dysfunction setting in. Then the standard is we look at an ultrasound guided procedure, select the vessel, whether it's a femoral, which side it is good, see for any DVTs, select the cannula size. The standard practice is to use a femoral for a drainage, position at IVC-RA junction, and use for IJV return, put it at the SVC-RA junction. The dual stage cannula we have used in cases, that is predominantly for the cases who had a deep venous thrombosis, we are not able to put the femoral cannula. The position of the final position of the cannula is totally guided by the echocardiography. So all cannulations were done by percutaneous method in our cases. We didn't have issues with the cannulations. Variations for 3 cases in whom we had to go for a veno arterial ECMO because the patients had a near arrest or an arrest at the time of initiation of ECMO. 2 of them were coming from outside centers, and by the time we reset them, they were severely hypoxic brady, so we were ready to insert ECMO. They were near arrest, put them on VA, then converted them to VAV because they'll have North-South syndrome. Then eventually a day or 2 later, wean off the arterial component and convert them to VV and support the VV care. That's how we progress for those 3 cases. Remaining all are VV ECMO right from the beginning. So if we have done in other centers outside our city or in some places where they have instituted by the other teams, close to 15 patients have been airlifted from different parts of the country to our site. In the same way, if you are lifting a patient who is not on ECMO, but who is on very high oxygen level, like more than 70% of oxygen at the time of lifting, we'll be ready here with all the things so that in case the patient comes in a crashing stage, right away we'll be ready to do the ECMO here. So the challenges for insertion, apart from regular ECMO insertion in any other situation, what I feel is a lot of insertion is that you have to do it in a COVID ICU where you have to put on the full PPE, probably a reflexes are not as brisk as they're in the other situation. And doing it in a lot of times in other situations across different places in the country, go there, put on ECMO and then shift the patient back in an aircraft. And unstable vitals, a lot of time you see them near crashing because of the hypoxia and hypercapnia, and choosing a cannulation site. DVT is quite common in this patient, so choosing the site and making sure that there is no thrombosis in the iliac veins or even higher up is should be ascertained before we go and cannulate these patients. So let us look at briefly what are the issues we had in maintaining these patients. The first one, as we see in most of them, is the bleeding. These are what we had the bleeding episodes in this patient. A good number of them, close to 10 patients, had gastrointestinal bleeding. Tracheostomy site bled in around close to 4 to 5 patients. Lung bleeding was there in 4 patients. 3 of them had a hemorrhagic stroke. So how we approach is we look at the coagulation profile of all these patients every day and manage them. Put a transfusion threshold of 20,000 for the platelets or 50,000 for any critical hemorrhage. And we run heparin-free ECMO. As soon as we see any bleeding beyond a level, the heparin will be stopped and try to manage with the heparin-free ECMO for a certain time. For most of the gastrointestinal bleeding, we were able to handle them. We had a good interventional gastroenterologist who do endoscopy or colonoscopy. And most of the time, the source of bleeding is at the GE junction or one of the rectal ulcers, which will be easily handled by an intervention. As a protocol, we put them on PPEs and stool softeners to make sure we don't have any issues from the gastrointestinal point of view. Even then, you see your GI bleeding being the most common source of bleeding in these patients. The second one is ECMO-related, circuit-related issues. Usually around 3 to 4 weeks is the life of oxygenator, what we have seen. Bring prothrombotic situation. In COVID, it may be required to change it a little more frequently. Keep a close watch on how the clots are there. Keep a close watch on the D-dimer levels. See whether you're running heparin-free ECMO, and then take a call on that patient. And once we have a doubt, we start monitoring delta P in almost all the patients and do post-membrane at regular intervals to take a call when we need to change. What we see is they don't tolerate even that short period of circuit change. That takes barely less than 30 seconds, barely 10 seconds or 15 seconds, where you have separate teams changing on the femoral end, separate team changing on the jugular end, and simultaneously someone is operating on the machine. Even that short period also, you see them not tolerating and going to the bradycardia. They'll be so critically dependent on the ECMO. Then other major issue, what you see in them is a critical illness neuromyopathy. Most of the patient, by the time you get an ECMO call or managed in the other places by, they'll be having persistent hypoxia for which they have sedated and paralyzed them for a very prolonged period, say for weeks. So by the time they come here, we totally stop paralyzing. We use paralyzing very sparsely unless it is really required. But what we see is these patients will have severe critical illness polyneuromyopathy, where they'll be barely able to move the fingers, a flicker of fingers, but otherwise they'll be fully conscious. So we go with all aggressive physiotherapy and rehabilitation for these patients, where we active and passive physio will be there. They have special machines which they use to make sure they can do the physio even in the bed itself. And even if the patients recover, to come out of this critical illness neuropathy usually takes weeks to months of rehabilitation for these patients. Then the next major thing, rather, which we deal in all of them is infection. As we know, the COVID-induced lung damage is pretty extensive, and this damaged lung forms an active foci for infection. And by the time we get a call, they would have been already had XDR bugs in them, already would have received all antibiotics what are there. We should have a very strict infection control measures. We have separate rooms for each patient. We have a team of ID and microbiologists who decide on the choice of antibiotics and infection control practices. If someone is going for a septic shock with early signs of MODS, we use a cytokine filter in the ECMO to take care of, to remove the cytokines. We have seen in whatever the few cases that helps in stabilizing the patient. This is an example of how the lungs are when they're explanted in the post-transplant, as we see extensively damaged, solidified, having cavities full of pus. This is how they are. So we will, obviously it will be very difficult to eradicate infection from these kind of lungs, and they keep on having septic episodes in spite of all your best possible measures. Then we are looking at long-term support, as I emphasized in the initially. They're going to be on ECMO for weeks to months, definitely. So if you are supporting a patient for long-term, taking care of them on all aspects is very, very important to have good outcomes. Nutrition has to be looked into. A lot of them become cakic sick, but once they come, we aggressively work on both calories and proteins, up to 2.5 grams per kg of proteins. Initiate oral feeds as soon as possible along with the RT feeds. Physiotherapy and mobilization has to happen in an aggressive phase. To prevent the pressure source. The cannulation sites, if you're planning to run an ECMO for a prolonged time, the cannulation sites can become a wound kind of thing or long-term changes. So that should be regularly monitored. Keep them in a negative fluid balance, and make sure a psychologist visits them regularly to make sure psychologically they're reasonably fine.
Dr. Murli, you have one more minute.
I'm almost done. There's a machine what our physiotherapists use to for both active and passive mobilization in the bed. The progress of the disease, we typically go both by the clinical and radiological measures. We do CT scan once in an interval of a week to 10 days to see how the disease is progressing. If the CT is 29 for male and 8 for female, the age group ranges from 25 to 71 years. The duration of support was 10 to 75 days, and someone is still getting continued more than 2.5 to 3 months of support as of now also. The data, total of 37 of we supported, 4 of them have totally recovered and gone off. Another 3 are in weaning mode where we can take it off. 8 have been transplanted. Another 8 are waiting currently for an organ availability. We had lost 16 patients, of which 6 plus were at a very late stage when they presented to us with very bad bleeding or a MODS or neurological issues by the time they presented to us. So this is the data in a nutshell. To sum up, VV ECMO is definitely a last resort where you're looking at 100% mortality unless you institute the ECMO. In the COVID, as we have seen, it is definitely takes time for the lung to recover, and the recovery of the lungs is still questionable. VV ECMO we have to look at as a long-term support, and we have to handle them, the infection, the nutrition, the physiotherapy aspects of it. If you're using it a bridge to recovery, it is better to institute early stage of the disease with a shorter duration of mechanical ventilation. If you're looking at it as a bridge to transplant, definitely yes, any point of time we can put it. and wait till we get an ORCAP. Thank you.
Thank you very much, Dr. Murli, for an excellent presentation of your data. I would now, before we go to a little bit of discussion on ECMO in COVID, I would now invite Dr. Orpon to present his data. And because Dr. Murli has already covered quite a few basic aspects of ECMO in COVID, I will request Orpon to stress more on the areas which are not covered in Dr. Murli's presentation. Please, Dr. Orpon.
Am I audible?
Yes, you are.
And seen also, eh?
Yes,
okay, fine.
You are.
Yeah. So whenever I present my data, it is the ECMO is an ECMO team effort. So I don't know why I'm get selected because of maybe my big mustache. So he selected me to present my data, and I'm presenting from the Medica in front. This thing I was a founder member of ECMO Kolkata, and this is my ECMO team, which was day in day out. They are working for the last 9 months. And we have started the program way beyond 2014 when a famous critical care specialist told us that India needs toilets, not ECMO. And today, after 6 years, probably it is the reverse. India is pioneer in the ECMO and also in the toilets. So you can find us in the ECMO availability map by the ELSO as a center number 738. And we are regularly putting our data over there. That's the problem with the ECMO physicians. When the patients come out of the ECMO, they can always ask what you have done, what is your job profile. So I cannot give the answer. I told them I'm an ECMO physician. Okay, doctor, well, that is fine, but what you do actually? So I told them, looking at the guy, he's a food delivery boy. I myself considered as a oxygen delivery boy, and that gives me a very good identity when we treat a critical COVID, because oxygen is the only supportive treatment which will be helpful in critical COVID, none other than the good critical care and low molecular heparin. So with this thing, we made a consensus document in the early part of the pandemic with the interdisciplinary ECMO providers, and I was a part of the team, and we made some guidelines for that. So current challenges, obviously in the pandemic, ECMO should be used as last resort. Everybody is telling that. But ECMO, we have to remind that ECMO came out from a pandemic, which was the H1N1 pandemic in 2009 from the Caesar trial. So you need something good to come out from a storm which is happening, that is kind of pandemic. And we are initially outdated by our Chinese data, which shows a 90% mortality from ECMO. And we came far beyond that. So how an ECMO is different in COVID? I told everybody that it's a marathon. You need not to be Usain Bolt. You have to be a Duti Chand to run your marathon. And all resources, obviously, and technique, as Murli Krishna told, all resources and technique should be utilized before ECMO. ECMO is different in COVID because it is done in a cohorted place. It is not your usual CTVS ITU where you are confident. You have to put that utmost staff safety. You should be you apply the remote monitoring, your cameras, your WhatsApp, your EICUs. You should do careful bronchoscopies and tracheostomies, handling of the membranes, and decannulation is as important as cannulation because you have to wear proper PPE also during the decannulation, and you have should have ethical plan for futility. And you should mind that no relatives of that sick patient is around. They are over your phone calls or they are on the other side of the email. So these are the problems with the ECMO in COVID. This is the paper cutting which have shown to us. I am feeling painful for that. 43% of our COVID-19 deaths in India is between 30 to 59 years of age. That means we have not used enough ECMO to rescue them because they are the bread earners of the family. So what so far we have done? We have done nothing, but we have only salvaged 51 cases till now, 49 VV and 2 VAV. Out of that 49, 31 cases of femorojugular and 18 cases of femoral. I am always, death is going ahead of me. My 25 patients died. Out of the ECL survival is 7 because they came out of ECMO and then died because of the Acinetobacter outbreak. It is not a COVID outbreak, they died of Acinetobacter outbreak. 19 patients went home, 3 patients on mechanical ventilation, still on after ECMO decannulation, and 4 on still ECMO running on. This is my data of 51 cases where I am, again, my death is ahead of me and I'm running behind it to get that statistics. Looking at the my complications, the ventilation to ECMO, the N90, the mean PF ratio is 0.65. 65% of my patients receive proning before ECMO. Renal replacement therapy is 30%. Myocarditis is 18%. Shock liver, 32%. Cerebral issues, 20%. Circuit thrombosis, I have seen 2 cases, which is deadly, and cytokine storm is not less than 30%. So these are the problems with the ECMO and thrombosis, early MODS, prolonged course, and the cytokine storm. So I am just sharing the challenges I have received. First is the retrieval, because we do retrieve ourselves. 23 patients we retrieve by ground transport from different parts of Kolkata and different parts of the Bengal by ground transport, and 2 patients we retrieve ourselves by air ambulance, because air ambulance don't take COVID patients. We have to wait for them to be negative, and then we take them from Siliguri and Bhubaneswar. Otherwise, the number would have been much more. And these are the few pictures when we retrieve in the other hospitals in Bellevue, in Woodlands, in like Durgapur, IQ City, anywhere. We put them on ECMO and we retrieve them with this kind of things. Wearing PPE is outside environment is really painful, and we have to bother that. And looking at the inside of the, this is the ECMO air transport where the patients were COVID negative, and we are in a small aircraft with this kind of patients, and this has to be learned. The challenge too, if your pneumonia is with the myocarditis, that's a problem. You have a big heart on VV ECMO and patient is on multiple inotropes. You have to see the BP is falling or the lactate is rising. You have to shift them to the VAV of ECMO. This is the third one, the day 9 of ECMO. It's a prolonged cytokine storm. Patient is receiving this kind of X-ray and you have a good flow, but the patient is having a very low blood pressures like this, and very unexplained tachycardia is happening and all this. So you have to use cytokine filters to take out that storm. Fourth one, that everybody has to learn, this ECMO inserted after 5th proning. These are the consequences of the late ECMO. And you are putting them on ECMO. With this patient, we put after 5th proning, he is not improving with the femoral approach, but we lost him due to massive ICH. They are much more sensitive to your changes of CO2 oxygen during the last 5 pronings. And when you put them on ECMO, and with this of this anticoagulation, he had a massive ICH. So you have to be careful putting ECMO late in the ventilation part. Challenge number 5, that is most of the patients on the latter part of their ECMO run had COVID encephalopathy. So this is a patient where the patient came out of ECMO very well, but he was on ventilator for a month because he was not responding. And that was the feature. You have to be careful, the COVID encephalopathy. And after that, when he went home, he is doing fine. So there is no residual effect. And decannulation, I want to show this picture. You are as prepared as your cannulation with the PPE. This is our success story, where obesity and COVID, we have done 6 patients of more than 120 kgs on COVID because they were not pronable. Whenever they got intubated, you have a PF ratio of less than 60, you put on ECMO. And with proud statement, I can tell you this, what Saswati told, that obese patients don't do well in ICU, but I because of out of my 6 patients, 5 patients went home, and I lost 1 patient of 160 kg because of some circuit problem. Otherwise, you would have been gone home. This is a patient of 130 kg went home. We came with a 9% saturation. 7, number challenge, refractory hypoxia. Even on VV ECMO, you get some low oxygenations. Like patient is having 87% oxygen. Patient is doing well, but not oxygenating well, even on ECMO. What has happened? So what we have done, we proned them on ECMO. Proning on ECMO, you have to learn if you run ECMO in COVID.
Dr. Orpon, you have 1 more minute.
Yeah, just prolonged ICU stay following COVID ECMO. You have to be prepared for that. What Dr. Murali Krishna told, this is a marathon. You have to wait for that. You have to go for a very good physiotherapy and rehab protocols with this. You have to learn how to mobilize them on ECMO. She is still with the dentist of 35 day old ECMO, and I'm mobilizing her on ECMO. And obviously work hard and party harder. Don't stop taking pictures, because this will give you the boost up in the next ECMO patients, where you will put, and then they will come out of this. Always take good pictures with your teammates. This is most important. Post-ECMO follow-up. Don't leave your post-ECMO patients to others. Give a good thromboprophylaxis follow-up, good assess regular residual lung function yourself, give a psychological boosting, and help them for the professional comeback, because they are the victims of the pandemic. They are otherwise doing fine, and they are coming back to you professionally very well. So this is my patient of Somnath, who has 38 days of ECMO, and he is doing very well at home after the 6 weeks of his recovery. So we are again in the transplant system. From the November, we got our permission from health department, and we are trying for that. And we have enrolled ourselves in the ECMO card study, which is worldwide doing. Our journey is ongoing. This is our ECMO ICU, separate ECMO ICU, which are made during this pandemic. And she is Somnath's daughter, who sent me the Happy New Year message last on 1st January. Thank you.
Thank you very much, Dr. Orpon. If you can stop sharing your screen. We are running a little late on time, so I would request Dr. Suresh if he wants to make any comments on the two presentations.
I think both the speakers spoke well, and nobody has the experience more than 1 year for a ECMO for a COVID lung. And one of the major problem in VV ECMO is the recirculation. So I'd like to ask Arpan, how often you see desaturation because of hypoxia related to recirculation, and how do you manage?
Sir, practically this with femorojugular cannulations is very rare. But significant portion of my ECMO is out of 18 patients, I put femoral, because femoral is very easy to shift, and it is very for retrieval also, and we get some kind of recirculation definitely, but with management of larger with the flow, reducing the flow and all this, I have managed it well. Because till date, recirculation has not caused too much problem with me. The problem which has happened to me is obviously what Murli told also. Sometimes these VV patients went into cytokine storm and hypotension and all these things, where I have to shift them to on VAV, and they didn't do well. Probably because of the severe RV dysfunction, I have thrombolized a couple of them, but they didn't do well. So that is the problem I have faced.
I think
yes. So we are running a little late on the program. So now I am extremely privileged to have Dr. Suresh now with us, and he will be presenting on the ultimate treatment strategy in COVID, even after venovenous ECMO, that is lung transplantation. Dr. Suresh, please go ahead and share your presentation.
Yeah. Good evening, all. A wide range of therapies starting from vitamin zinc to ECMO and lung transplantations have been offered for COVID-affected patients, depending upon the severity of the illness. And this is the institution where we offer such services to the COVID-19 patients. Now, the process of lung transplantation for COVID-affected lungs is a complex procedure. I will try to cover it in 15 minutes or save some time for the discussion, and also try to simplify it under the following headings. I'll discuss about the indications, contraindications, a few points about the transplantation procedure and the intraoperative considerations, and also about the postoperative management. Finally, I will share our own experiences about the lung transplantation. Yeah, The pneumonia associated with the COVID-19 can lead to respiratory failure in 10% of the patients. And sometimes profound hypoxemia can lead on to endotracheal intubation and mechanical ventilation. However, the mortality rate in such situations is high, around 60%. Patients who are not responding to conventional mechanical ventilation may be candidates for ECMO as a bridge to transplant or as a bridge to recovery. Looking back at the history of lung transplantation, the first human lung transplantation was done by James Hardy in 1963. However, the patient did not survive. The first surviving lung transplant was done by Bruce Reitz in 1981, and Dr. Joel Cooper did the first surviving double lung transplantation in 1986. And the first successful double lung transplantation for COVID-19 destroyed lung is done in 2020. If you look at the total figures, annually around 5,000 lung transplants were done all over the world. Now, when to consider lung transplantation for COVID-19 affected patients? The age should be less than 65 years, and there should be a single organ dysfunction, that is the lung. And you need to allow sufficient time for the lungs to recover, especially if the patient is on ECMO. And there should be radiological evidence of irreversible lung disease, such as bullous destruction or established fibrosis. And patient should be awake, he should be able to understand things about the lung transplantation. And they should be able to participate in the physical rehabilitation, because they need to cough or do physiotherapy once the lung transplantation is over. Patients should fulfill all the typical criteria for transplant, and the RT-PCR should be negative from the deep respiratory tract sample. And the transplant center should have substantial experience in high-risk ECMO and the lung transplant. Of course, you need to have access to the donor pool. Now, what are the contraindications? Recent malignancy, multi-organ dysfunction, active hepatitis B or C, chest wall deformities, psychiatric illness, obesity, lack of social support, and the history of substance abuse. All these are contraindications for lung transplantation. Now, when you start the procedure of lung transplantation, you'll have challenges. They will have high levels of HLA antibody because of the repeated blood transfusions, as also because of the blood product transfusions. Again, infection is a major problem. The lung is a source of bacteria, and you will have MDR bugs. And also the oxygenator also may be source of bacteria if the patient is on ECMO. Of course, they will have coagulation abnormalities, especially when they are on ECMO. There also may be platelet dysfunction. And finally, availability of organs is a major issue, especially at the right time. So what are the criteria to accept the lungs in a brain dead donor? The age of the brain dead donor should be less than 55 years. Of course, now we have extended that criteria, and it should be ABO compatible lung. The X-ray chest should be clear. PF ratio should be more than 300. And ideally, the patient should not have any smoking history. If at all, it should be less than 20 pack years. And there should not be any evidence of aspiration. And the donor should not undergo or should not have a history of surgery under cardiopulmonary bypass, because they will have adhesions, difficult to dissect the lung. And bronchoscopy should not reveal any purulent secretions. So coming to the surgery, usually we do the clamshell incision at the fourth intercostal space. And all these procedures are done on ECMO. If the patient is on VV ECMO, we'll convert that into veno-arterial ECMO using the aortic cannulation. And about the surgery, the bronchial anastomosis is done first, then the pulmonary artery anastomosis, and finally pulmonary venous anastomosis. Before release of clamp, we have to make sure that dearring is done. And once the transplantation is over, bronchoscopy is required to look at the bronchial anastomosis to prevent any narrowing and also to clear out the secretions. And transesophageal echo is useful to assess the anastomosis in the pulmonary artery and the pulmonary vein, and also assessing the right ventricular function, especially if the patient has got pulmonary arterial hypertension. Bleeding is an issue. They may require a lot of products, platelets, and fluid management is very important in these patients. If you give more fluid, it may result in lung congestion and primary graft dysfunction. So we follow restrictive fluid management, and ventilation is an important issue. We use protective ventilation. That means tidal volume of 6 ml per kg or less, and driving pressure should not be more than 15 centimeter of water. And nitric oxide does play a role in reducing the pulmonary arterial hypertension. And immunosuppression, we use triple drug regime, methylprednisolone, tacrolimus, and mycophenolate. We avoid IL-2 receptors because the patients are more prone for infection with the usage of IL-2 receptors. And talking about our own experience with lung transplantation, we have done so far 8 such transplant in COVID-affected patients, out of which 7 patients were on ECMO in the preoperative period. The total duration of ECMO ranged from 29 days to 70 days with a mean duration of 45 days. We had 2 mortality in the immediate post-operative period and 1 late death. 5 patients are surviving and doing well. So I will discuss about the first case who had a lung transplantation, a 49-year-old male from Delhi, known hypertensive, admitted with fever, breathlessness. Then he was tested positive for COVID, and the hospital tried NIV, prone positioning, and high flow nasal oxygen, but finally he got intubated because of the poor oxygenation. They tried to wean off ventilation, but in vain, and finally he underwent tracheostomy. He became COVID negative on 24th June, but his CT chest showed extensive bilateral ground glass opacities, and he was ventilator dependent. He was airlifted to MGM Healthcare, and we repeated the chest CT. There was widespread ground glass opacities, fibrosis. So his lung complaints worsened. He had poor oxygenation, so we put him on VV ECMO. We used a 17 French return cannula through the interjugular vein and 23 French access cannula through the femoral vein. Then we waited, but his lung complaints did not improve. Repeated CT showed extensive fibrosis. There was no improvement in the lung condition. So hence, we counseled him for a lung transplantation, and we continued the ECMO as a bridge to transplant. This is a patient on ECMO waiting for a lung transplant. And we continued the ECMO for more than a month. And finally, he was lucky enough to get a brain dead donor, and bilateral lung transplantation was done on 28th August. And he was weaned off from ventilator weaned off the ECMO on the table itself and weaned off the ventilator on the post-op day 1. He was on TPs on the next day. However, because of the long ICU stay, he had profound muscle weakness. This is the lung transplantation surgery where the surgeon is doing the bronchial anastomosis. And this is the explanted lung, totally destroyed. We did microscopic examination of the destroyed lung. It showed multiple hemorrhages, multiple abscesses, fibrosis, and neutrophil infiltrations. We also sent it for electron microscopic study at Vellore, which showed again fibrosis, total destruction of the alveolar cells, especially the type 2 pneumocytes. And you can see the chest X-ray post-lung transplantation and the patient on the left side. We do routine bronchoscopies in the post-transplant period, one to look at the anastomosis and also to clear off the secretions. and active physiotherapy is required. This is the Lato 2 machine to give physiotherapy for the lower limbs and the upper limbs. And finally, we could shift him out of the ICU after almost a month's stay in the ICU. This is the paper sent for publication, International Experience of First National Lung Transplants for COVID-associated acute respiratory distress syndrome. We are part of the study. This is again a paper about our series of lung transplantations, and it has been accepted for presentation in the ISHLT 2021 meet, which is to be held in Toronto, Canada. The complex lung transplantation and the ECMO requires a large experienced team and also other facilities. We are fortunate to have good resources at MGM Healthcare. I thank you for the patient listening. Thank you all.
Thank you very much, Dr. Suresh, for an excellent presentation. And this is something all of us were looking forward to listen to because the entire country still not has got much of an experience in post-COVID lung transplant. So thank you again. We are still running a little late on time. So if there's any questions, we'll just take them right at the end of the program. And I would now like to invite Professor Dr. Abhijit Hajra, who's a professor of pharmacology. Professor Hajra is a senior in my college. He's also the Dean of Student Affairs in Institute of Postgraduate Medical Education and Research. And he's going to speak about vaccination for COVID, which one of us is looking forward to in 2021. What is the situation and how it is going to unfold? Dr. Hajra, please.
Okay, good evening, Dr. Rahul. Am I audible?
Yes, you are perfectly audible.
Okay. I've been around for some time and listening to the last few presentations on ECMO and lung transplant. So I feel a little like fish out of water and in need for ventilation myself. Anyway, you have selected me for speaking on this topic, which is quite in a bit of flux and evolution, and I feel honored to be part of this presentation today. I'll do screen share.
Yeah, we can see it. Yeah.
Okay. So this will be a brief presentation on the COVID-19 vaccine, the prospects and challenges. Now, as we all know, this new virus, the SARS CoV2, belongs to the beta coronavirus family. And this is just a schematic representation of the virus. And you can look at, it looks quite formidable. It's a single-stranded RNA virus. There's a tiny bit of RNA material and quite a few viral proteins, out of which the one which is sticking out like a spike, the spike glycoprotein S, is crucial to the entry of the virus into the host cells. So cells having the human angiotensin AC2 receptor, they are susceptible to virus attack. And these cells are present in the respiratory tract, lung parenchyma, type 2 alveolar pneumocytes, and some other cells in the body. Now, just a caveat here, in my slide presentation, I'll be using some images. Now, some of these images I know are copyright free, but I'm not sure about the copyright status of others. But if I'm breaking any copyright, that is entirely unintentional. And if someone points it out, I'll remove that picture. Very briefly on the pathogenesis of this virus. It's a remarkable virus in the sense that it behaves like other coronaviruses with which we have been familiar for quite some time. The spike protein binding to the ACE2 receptor provides the pull protein, and once inside the host cell, the virus undergoes uncoating. Then the viral RNA remains there in the cellular genome for some time, and then it gets translated to new virions, and these new ones are released and they go on to infect subsequent cells. So we know that the whole process does not take too long. Maybe the incubation period is about 6 to 8 days, and the symptoms tend to peak after the first 7 to 8 days. And then the course is either towards recovery, fortunately in the majority of cases, but the virus also has a few tricks up its sleeves. For instance, it can induce a cytokine storm, unlike most of the other coronaviruses that we know of or other respiratory viruses, in which case the course will go downhill. Now, being a member of the beta coronavirus family, it's known to stimulate the immune system. Both the humoral and the cellular immune components are there. So the viral proteins, they are presented on the surface of antigen-presenting cells. And the primary immune cells, which take on the responsibility of activating the immune system, are the T helper cells. And the T helper cells, they drive a cell-based immune response by activating the cytotoxic T cells. And on the other side, they also provoke humoral immunity by activating B cells. And the B cells, they generate antibodies through the intermediate plasma cells. And these antibodies, they either prevent the virus from binding to the host cells, or they envelop the virus, tagging it for destruction. It is also believed that there is a population of B memory cells and T memory cells, which would be capable of providing long-lasting immunity to the SARS CoV-2. So in that way, the mechanism of pathogenesis and the mechanism of immunity is quite well established and known. And this has helped us in the race towards a COVID vaccine. Now, why do we need a COVID vaccine? Now, we all agree that this COVID-19 pandemic is the worst crisis facing mankind since the days of World War II. Everyone is emphasizing preventive measures. They're important, but masks, other personal protective equipment, secure distancing, so on and so forth, can only provide protection to a degree. They cannot provide long-lasting solution or a durable solution to this pandemic problem. No effective chemotherapy is in sight. Repurposed drugs are being used for prophylaxis or supportive treatment, often on the basis of scant evidence. In fact, probably other than dexamethasone and steroids, the evidence is very much fragmentary for whatever else is being tried. And even plasma therapy, which initially had raised a lot of hope, seems to be doubtful now. So in such a scenario, we all agree that vaccines hold the promise of a return to normalcy. And the aim of the COVID vaccine, like for other vaccines, would be to provide an antigenic stimulus that won't cause disease, but will provoke the immune system, will activate the immune system so that it can kill the virus if the person gets infected. The interesting thing is the nature of stimulus which is being tried. And as of last count, WHO runs a program of this COVID-19 vaccine registry, and I was looking at it 2 days back, and it says that more than 230 vaccines are being developed against COVID-19 by research teams. Some of them are university-based, but the majority are based in pharmaceutical companies. And new technologies are being tried, some of which are entirely novel. For instance, the mRNA vaccines, they're novel, and they've never been used in licensed vaccines before. So as of now, at least 60 vaccines are in clinical trials, of which 5, that of the Russian company Gamaleya, which they have named as Sputnik 5, that of Pfizer-BioNTech, which has a code name BNT162V2, that of Oxford University and AstraZeneca, the combined endeavor, they have named it the ChAdOx1 vaccine, and the vaccines from Moderna, which is a US-based vaccine, and Sinopharm, which is a Chinese pharmaceutical company. These 5 vaccines have received licensing for human use. The Pfizer-BioNTech vaccine was the first to get emergency use authorization sometime in early November, but subsequently it has got full authorization for use in UK, US, and some other countries. Now, if you look at the pace of vaccine development and the ethos surrounding it, we can say that vaccine development is progressing against tremendous odds. The entire resources of mankind, the biomedical research, is being diverted to this vital arena, and it is also progressing under intense socio-political scrutiny. So these are things in themselves to be studied and reported on in future. Now, broadly, all these vaccines, 200 plus vaccines, they can be divided into four families, four broad families, some of them which are based upon the whole virions, of course, inactivated or weakened. Some of them are using viral vectors to deliver the COVID-19 proteins to the human immune system. Some of them are using nucleic acids, RNAs and DNAs, which would be transcribed to viral proteins within the human system. And some are supplying the proteins themselves, either as protein subunits or empty viral shells. There are also other approaches. For instance, there's an interesting hypothesis that if you can stimulate the immune system by, let's say, a BCG vaccine or the oral polio vaccine, then that will provoke a general immune response, which might also be effective against COVID-19. But those approaches are still experimental and not in clinical trials. So very briefly, we can review this four kinds of vaccine families. So the virus vaccines, they're an age-old concept. If you can attenuate the virus, weaken its pathogenic potential by passing it through human and animal cells, and then inject this into the human system, then they will provoke the antigen presenting cells to do their bit without themselves causing disease. Now, if the virus is weakened, the stimulus would be stronger, but if we are using the kill virions to stimulate the immune system, they will have to use adjuvants along with it. So this is an approach which is being followed by some of the companies, and in India, we have our Serum Institute researching on this vaccine in collaboration with some companies in the United States. Now, viral vector vaccines. The viral vectors vaccines is exemplified by the approach which has been taken by Oxford University in combination with this Anglo-Swedish AstraZeneca company and also the Chinese pharmaceutical company Sinopharm. So what they're using viral vectors to carry viral genomes, genetic material specific to SARS CoV-2 into the host cells. And in case of the Oxford AstraZeneca vaccine, they are using chimpanzee adenovirus vector to carry the genes into the human system, and the viral genes that would be replicated inside the human system. Attenuated virions would be generated, and the antigens would be incorporated into the antigen presenting cells, and they will stimulate a humoral and cellular immune response. Okay. Now, so this approach, the viral vector would replicate within the human system. There are also approaches using non-replicating viral vectors, but these non-replicating viral vectors are not yet in clinical trial, and their development might be more difficult than using the replicating viral vectors. Nucleic acid vaccines, that is exemplified by both the Pfizer-BioNTech vaccine and the Moderna vaccine. What they will do, they will try to force viral genetic material. They will try to force viral genetic material or viral proteins into the host cells, and these viral proteins would then be expressed on antigen protecting cells, and they will in turn stimulate the immune system. Since you cannot incorporate naked DNA material into the host cells, you have to find some mechanism. For instance, lipid vesicles can be used to transport viral messenger RNA into the host cells. So conceptually, this RNA and DNA-based vaccines are easier to develop, and they are not dangerous because they'll be delivering only the viral genetic material, not the full virions. But the thing to note that this technology has not been used in any human vaccine so far. And there are no licensed vaccines that use this technology. Protein-based vaccines. Now, several teams are working on vaccines with viral protein subunits. And most of them are focusing on the virus spike proteins. So the proteins would be directly introduced into the system, and they will be incorporated into the antigen presenting cells. There are some technical challenges to be solved here, but then subsequently they will stimulate the immune response. So in addition to protein subunits, some teams are trying to use entire virus-like particles. They're using the viral shell or envelopes without the genetic material. But again, this can be difficult to manufacture, to produce as a stable formulation, and we don't have any clinical examples of this virus-like particle-based vaccines so far. Now, conceiving a virus technology is relatively easy, but putting it into practice has to overcome a number of challenges, including the challenges of producing the vaccine and showing its effectiveness in different types of testing. The thing to know here is all the clinical trials that have been done so far, phase 1 to phase 3, have actually relied on surrogate markers. People are trying to see whether 1 or 2 doses of vaccines would be stimulating the immune response, mostly the humoral immune response, the production of antibodies with specificity against the spike proteins or other SARS CoV-2 proteins. Some of them are looking at the cellular immune response too as a secondary endpoints. None of them are as yet looking at hard clinical endpoints, the extent of protection which the vaccines will afford in case of actual exposure, actual clinical exposure to SARS CoV-2. But that is not the only challenge. You see the research on SARS CoV-2 vaccine started in the early part of 2020, and because a lot of information is already available regarding the coronavirus, including from the earlier outbreak of SARS and MERS viruses, some of the academic research have skipped, have allowed vaccines to go into preclinical development and then phase 1, phase 2, phase 3 clinical trials. Things are being fast-tracked. Science is demanding, so things are being fast-tracked. Many of the vaccines have undergone combined phase 1, phase 2 trials and then directly into phase 3 trials. And in fact, apart from Oxford AstraZeneca vaccine, there are no large reports in of the effectiveness of the vaccine. So much of it is what the manufacturers themselves or the developers themselves are saying about the vaccine. And there is no independent scrutiny of the findings or the trials. But you cannot wait for a vaccine to succeed and then take a decision for manufacturing. You'll have to gear up your production facilities before it. So once the approval comes, and people believe that the first approvals will come only in 2021, but fortunately, the first approvals have come in the closing days of 2020. We had the first emergency use authorization of the Pfizer-BioNTech vaccines somewhere around 8 November in USA. But then in the last week of December, both the vaccines have received approval for general use in several countries. And today the report in the newspaper is that yesterday our task force in India, which advises our central drugs regulator, they have recommended for approval of the vaccine. And we believe that it's a matter of time, maybe tomorrow or day after, where our national regulator, CDSCO, would also be approving the AstraZeneca Oxford vaccine. So the challenges is in gearing up production facility and gearing up distribution, maintaining the cold chain. So why do we need a cold chain? I'm coming to that just now. So just 2 pictures to break the monotony. 90-year-old Margaret Keenan of UK, grandmother, was the first person to get the Pfizer-BioNTech vaccine outside of a trial. In fact, she's the first person to be officially designated as a COVID vaccinee, the first COVID vaccine in the world. And in the USA, the first person to get the vaccine was Sandra Lindsay, who is a critical care nurse in a New York hospital. Okay, and as per reports in today's press, the USA is leading in the number of vaccines, 1.7 million, but China seems to have overtaken the USA and is also racing ahead, but they're using their own vaccine, the Sinopharm vaccine.
Dr. Abhijit, you have 1 more minute.
Yes, I'll be complaining it. So a few points regarding the Oxford AstraZeneca vaccine, which is probably the first vaccine that we are going to see rolled out in India. Is only one with published report in peer-reviewed literature. You can find a report in Lancet. It uses the chimpanzee adenovirus as a vector to introduce the SARS CoV-2 spike protein in the system, hoping to stimulate the antigen-presenting cells in the process. It is relatively inexpensive and will require storage in the normal cold chain conditions of 2 to 8 degrees centigrade. So far, it has been determined that it has to be administered intramuscularly at 2 doses, but the time interval between 2 doses is still being worked out, anything between 4 to 12 weeks it is. The immunogenicity has been assessed primarily by the total IgG assessed through ELISA against the CoV-2 spike protein, but a lot of other assays have been done. Protection would be believed to be around 62% with the first shot, which can go up to 90% with the second shot. Common side effects are there, but these are all minor reactions and can be easily removed with paracetamol. And there is one single report of transverse myelitis, but the causality is still being worked out. And these are the other vaccines which are lined up and which may get rolled out. India will need 1.3 billion doses of vaccines if we are to cover the entire population. And in the first shot, we'll be needing around 300 million doses. And so we need as many vaccine providers as we can. But the problem with Moderna and Pfizer's biotech vaccines are that they're going to be more costly. The new technology, the RNA technology, which has never been used in licensed vaccines before, and they require more stringent cold chain conditions. The Pfizer's vaccine, for instance, requires minus 70 degrees centigrade storage, which is a real challenge for carrying the vaccine into smaller towns and to rural India. But the advantage, the postulated advantage is 95% protection right from the first shot. The Sputnik 5 vaccine is also undergoing clinical trials in India. And we are also doing trials in Kolkata. Peerless Hospital has been entrusted with the first in Kolkata to start trials of this vaccine. So India is likely to roll out with the Shadox 1 vaccine. I personally believe that it would be towards the end of January or early February, but many challenges remain. What would be the effectiveness in the face of actual clinical exposure? Will differential protection affect herd immunity? What proportion of the population needs to be vaccinated to achieve adequate herd immunity? Maintaining the cold chain, training and deploying an adequate number of vaccinators. Today, we are having a dry run in many parts of the country, and they're trying also the WinCovid software for documenting the vaccination process, maintaining the vaccination records. And an important question for the government, should the first goal be to administer 2 doses to healthcare workers to complete their primary immunization, or to get 1 dose across to as many people as possible? You cannot do both with 300 million doses at present. If 2 doses, what should be the appropriate interval between doses? And what is the likelihood of serious adverse events like anaphylaxis, Guillain-Barré syndrome, and transverse myelitis? So organizing adverse event following immunization activities in relation to corona vaccines is a big challenge, and we are gearing up. State-wise task forces are being set up, and at IPGMER, we are also being asked to take some of the responsibility of this AFI. But overshadowing all these challenges is the unanswered question, will viral mutation nullify the benefits of ongoing vaccination? Would it be like the influenza vaccine that so long as this new virus is endemic, would we require a new vaccine strains and new vaccines to be developed every year? that would again bring it with immense public health challenges. So thank you. And as we begin the new year on a positive note, let us hope that the vaccines that we are going to use, they will be effective. Humankind has spent a lot of effort, time, money, and intellectual effort. And I believe that not all vaccine candidates would be successful. It's a statistical improbability. But even if 1 or 2 candidates are successful and we are able to cover 60 to 70% of the population, as the public health experts say, then we will be able to return to a state of normalcy. Thank you, Rahul. Over to you.
Thank you, Dr. Ovijit, for an extensive and comprehensive update on the status of vaccines all over the world, in particular India. And at this moment, on behalf of AICTA West Bengal, I would like to thank all the moderators, our senior colleagues in the society, and the speakers for coming, and obviously the audience who was always there to listen to the important presentations. At this moment, I would also like to thank Dr. Shomi Dash, our Honorable Scientific Secretary, for putting up a fantastic program 9 months into the COVID pandemic. And of course, Dr. Ashok Verma, our Secretary of the Society, for implementing the entire scientific syllabus and giving us an excellent platform to deliberate. At this moment, I will hand over the microphone to Dr. Ashok to thank everybody and conclude the program.
Yes. On behalf of WBC-TBA, my sincere thanks to all the eminent speakers and moderators for taking time out of the busy schedule. And my sincere thanks to our President, Dr. Gaurav, and Senior Vice President, Dr. Rahul, and Junior Vice President, Dr. Manish, and my special thanks to our Scientific Secretary, Dr. Shomi. Thank you all for everyone. Thank you very much and Happy New Year.
Thank you and bye, everybody.
Thank you.
Thank you. Thank you.
Happy New Year and bye-bye.
Happy New Year, Sekada.
Thank you.